Hello, everybody. Thanks for joining us today for the first installment of your ACR TI-RAD webinar. This one is on This is How We Do It. This session will be recorded and made available after the webinar ends. My name is Jenny Hong, and I'll be moderating and presenting today. I'm a neuroradiologist at Duke University. Now, let me introduce you to our speakers today. Hi, Bill. Hi, Franklin.
Hi, Jenny.
Hello. Dr. Franklin Tesler is a professor of radiology at University of Alabama, Birmingham. He's had more than 30 years of thyroid ultrasound experience and a deep knowledge of the literature, and he took on the role as a chair of the ACR TI-RADS committee and was a sensational leader. Through the process of working with him, I also learned that he was capable of writing very long emails. Dr. Bill Middleton is a professor of radiology at Mollenkrodt Institute of Radiology. He is a national leader in thyroid ultrasound as well. Bill was a key member of the ACR TI-RADS committee. In particular, he had available a multi-center study with the Society of Radiologists in Ultrasound, and it's through his work with that society that we got a database of more than 3,400 nodules, which allowed us to test our preliminary models and really make ACR TI-RADS evidence-based. An interesting fact about Bill, since we're in the Olympics now, is that Bill was invited to participate in the Olympics. Not as an athlete, but Bill provided ultrasound to the athletes. Now, my role on the committee is really pushing research forward. We have several publications which are now in press, and I'm a principal investigator on a multi-center registry project, which is funded by the ACR and also Akron. Three of us came together at RSNA, and we really felt strongly that we're on a mission to change the way thyroid ultrasound is performed. We wanted to change the management of thyroid nodules for patients and also add to the value of radiologists and other providers. And this is why we were motivated to do this webinar. We were not asked to do it. This is through our own initiative because we really feel strongly that the next step forward is to share what we know and what we can do with you. None of us have any disclosures of relevance. And here is the agenda. When we got together, we decided that one webinar was not enough. So we have three, and I'll tell you about the others later. But first of all, the agenda is for Franklin to take over first, and he's going to describe ACR TI-RADS. He's going to tell you about the rationale of the committee, and he will give you some tips on implementation in your practice and how you can use it. Then Bill is going to spend some time going through cases with you. He's going to go through the lexicon of ACR TI-RADS so that you can interpret your nodules with confidence. And then I'll finish off with a short presentation of the structured reporting template that you could use and also give you a website where you can get some additional resources. Then the last part of the webinar, hopefully a good 20 minutes of it, will be time for you to ask questions. And so feel free to send your questions in during the talks. I'll collect them all at the end and we'll send them off to the speakers and they can answer your questions. Now, remember I said this webinar is going to be recorded, so if you still have to step away or you think that someone else you know would be interested, you can access the recording after this webinar is finished. Another feature that we're going to add is some live blogging. This is through hashtag ACR TI-RADS, and you can mention Radiology ACR or Franklin and myself. Now that we want to learn about you. Who are you? Are you a radiologist, a radiology trainee, a physician who is not a radiologist, a sonographer, or other? Send your answers in. In this time, I also want to acknowledge Lauren Hicks, who has been organising this webinar behind the scenes. Okay, so 3/4 of you are radiologists. Great. The next question for you is, Are you using ACR TI-RADs? Yes, no, but you will be doing it in the next 6 months, and no, no plans in the near future. Now let's take a look at your answers. Great. Okay, so I really think that this webinar is going to be of practical use to all of you, particularly the more than 80% who are actually using it or will be using it in the near future. Now I'm going to give the presentation over to Franklin, who is going to do the first part, really laying down the foundation behind the rationale, implementation, and tips to use in practice. Franklin, you should have control now.
Thank you, Jenny, for that kind introduction, and thanks everybody for attending. Thomas Wharton named the thyroid gland in the 17th century. He thought that it resembled the ancient Greek shield that's depicted on this coin. Little did he know what he was starting, because he certainly didn't know anything about thyroid nodules. And in fact, he thought that the function of the thyroid gland was to lubricate and insulate the neck. The rationale for ACR TI-RADs is illustrated in this chart. Only a small percentage of thyroid nodules are detected by palpation, less than 10% in some studies. At autopsy series, nodules are found in clinically normal thyroid glands in 50%, whereas high resolution of ultrasound, defined as being 13 megahertz or higher, detects nodules in as many as 68% of thyroid glands. And in fact, I think this number is actually low. In this study, they used a threshold of 5 millimeters for defining a thyroid nodule, but we frequently see nodules that are even smaller. So thyroid nodules are extremely common, and the problem is that the vast majority of them are benign. Only a small percentage, less than 5%, are malignant. Therefore, we need to be able to figure out, based on what we see, which ones deserve further attention. Several professional groups over the years have been involved in this effort. In 2004, the Society of Radiologists and Ultrasound convened a consensus conference in Washington, D.C. And this page from the radiology article that was published the following year shows the consensus statement that was presented. Here's a table from that paper. On the left, we see ultrasound features starting out with more suspicious ones at the top, such as microcalcifications, down to less suspicious nodules, such as mixed solid and cystic. And on the right, you see the corresponding recommendations. As the nodules become less suspicious, the threshold for recommending an FNA in terms of size goes up. And that's a theme that we see in multiple risk stratification systems that have appeared since. The American Thyroid Association has also published guidelines for management of thyroid nodules, and this is a chart from their most recent set of recommendations from 2015. Unlike the table that I just showed you, this is pattern-based. So there are a number of patterns of appearance of ultrasound for thyroid nodules, and you look at a particular nodule, pick the pattern that it most closely matches, and determine management based on that. Unfortunately, this is sometimes problematic because in a number of cases, a particular thyroid nodule will not fit any one of these patterns and therefore won't be classified. Multiple other groups have been involved over the years as well. Several of them have used the acronym TI-RADs based on BI-RADS, which is famous in breast imaging. This is the most recent one from the European Thyroid Association. It was published last year, and they called it EU TI-RADs, EU for Europe. And this is a chart from their paper, and it shows that if you have a nodule in their scheme with at least one high suspicion feature, which they define as a non-oval or round shape, irregular margins, microcalcifications, or marked decreased echogenicity, they consider that high risk. Although, as you can see, there's a wide range of risks in that category. And for that, they say, if the nodule is less than 10 millimeters, you do either FNA or follow it, and FNA if it's larger than 10 millimeters rather than 10 centimeters. There are two things about this I'd like to point out. First of all, is they identified a round shape as being a suspicious feature. And I found that a lot of small nodules, which are hard to measure accurately when they're that tiny, are round. The other is that if you want to be picky about it, their chart doesn't say what to do with a nodule if a nodule is actually exactly 10 millimeters. This says less and this says greater than. But still, they've adopted a general approach that's similar to what other groups have taken. As all this was going on, several people in different countries were looking at what all this was accomplishing. In South Korea, thyroid nodule screening has been offered for a small add-on cost since the late 1990s and early 2000s. And since this was put in place, as you can see in this chart, the incidence of thyroid cancer, mostly papillary, rose tremendously. But if you look at the line that's hugging the x-axis here that represents thyroid cancer mortality, it remained extremely low throughout this period, suggesting that it wasn't having a meaningful effect on patients. This was highlighted in an article in the New England Journal of Medicine in 2016 that we quoted in our white paper. And in this article, it was stated that overdiagnosis of thyroid cancer accounted for a substantial percentage of cases of thyroid cancer in the US, which again suggested that we were seeing a lot of nodules that weren't clinically significant. The basis for ACR TI-RADs was presented in our lexicon paper, which was published in the JACR in 2015. And this table shows the lexicon. There are 5 categories that I'll return to in the TI-RADS chart, ranging composition, echogenicity, shape, margins, and echogenic foci. And I've highlighted in red the more suspicious features in each of those categories. And Bill Middleton will be showing examples of these shortly. In our deliberations, we decided to do several things that departed from what other groups had done. First of all, we wanted to be points-based and not pattern-based for the reason I mentioned earlier related to the ATA guidelines. Second, we wanted no half points because the math would be easier with integers. Third, we decided not to have A, B, and C subcategories as some other systems have used, again, to make it simpler. And finally, no category for normal thyroid because you hardly ever see a normal thyroid anyway, and that would be a good waste of a category. Remember that these are guidelines and not standards. That is, it's up to the practitioner who's reporting a thyroid nodule to decide what to do in a given case, and extenuating circumstances may apply. This is the basis, the central point of ACR TI-RADs. It's our chart. And this is meant to be put up in reading rooms and elsewhere, as I'll describe. Here are the 5 categories at the top: composition, echogenicity, shape, margin, and echogenic foci. In each of these, going from one to the other, you choose the one category that applies for that, the one feature rather that applies for that category, whether it's composition, echogenicity, shape, and margin. The only exception is echogenic foci, the last category, because these features are not mutually exclusive and more than one of them may be present in a given nodule. Once you have all the points, you add them up and you end up with a TI-RADS or TR level, ranging from TR1 to TR5. And the annotations below TR3, TR4, and TR5 indicate what management to recommend based on the maximum dimension of the nodule, whether it's a fine needle aspiration, FNA, or follow-up. If follow-up is not, if the nodule size is below the threshold for follow-up, no further follow-up is recommended. And the boxes at the bottom have explanatory notes that help apply each of these categories. Some of our decision-making in developing ACR TI-RADs was informed by a multi-institutional study that Bill Middleton and co-workers published later that year. And as you can see, as you go up from 0 to 10 points, the risk of cancer goes up as you'd expect. But still, in the intermediate category of TR4, you'll notice that the risk is still fairly low, and it only goes up really much higher in the higher risk category of TR5. I want to spend a moment or two on partially cystic nodules because I think these give people, including myself, problems. It's important to recognize that the appearance of the solid component predominates, and suspicious features of the solid component, including eccentricity, punctate echogenic foci, and lobulation, are concerning. That's illustrated in this image from the literature that shows a partially cystic nodule that has a mural component that has some punctate echogenic foci and is lobulated, and this was a papillary thyroid cancer. A moment or two, I know Bill Middleton will return to this as well, about spongiform nodules, which are not suspicious. To be spongiform, they have to be comprised of at least 50% of small cystic spaces. It's really easy to overcall these, and if any doubt, as in this nodule, it should be called solid. The American Thyroid Association does somewhat the same thing for mixed cystic and solid nodules, and they call attention to these same features of eccentricity that I just mentioned a moment ago. For definition of growth, we offer two options. The first, with just linear dimensions, is a 20% increase in at least 2 nodule dimensions and a minimal increase of 2 millimeters, or if you want to calculate the volume, a 50% or greater increase, and Bill will show you how to do that. For follow-up intervals, there was not a lot of good material and literature to go on, but we thought that for more suspicious nodules like TR5, more frequent follow-up was warranted. So annually for 5 years for TR5, a little less for TR4, and even less for TR3. And the 5-year threshold was based on some work that shows that if a nodule remains static in size, not changing for 5 years, it's very likely benign. Previously sampled nodules are not encompassed in ACR TI-RADs and may require molecular or gene expression classifier testing, and their management is usually driven by physician request. In multinodular glands, in which there are multiple nodules with similar characteristics, or they're confluent or there's diffuse heterogeneity, FNA is usually not indicated. On the other hand, in a multinodular gland where one nodule is higher risk than the others based on our classification scheme, FNA may be warranted. Here's an example of a heterogeneous gland for which FNA is not indicated. Lymph nodes are not formally included in ACR TI-RADs either. However, their appearance may influence the decision to biopsy a nodule. The lymph nodes may be scanned at the time of the initial sonogram, at the time of the FNA, or subsequently after malignancy has been confirmed. Finally, I want to close with a few points on implementation of ACR TI-RADs from a practical perspective. First, I think it's valuable to give everybody on the team, including physicians, sonographers, or whoever else may be involved, the ACR lexicon and ACR TI-RADs white papers, and then meet as a group to review, so you're all on the same page in terms of what you're doing and how you're describing things. Second, it's very helpful to make the chart available everywhere. And by everywhere, I mean not just in the reading rooms, in the scanning rooms as well, because as I'll mention shortly, it's important for sonographers to be familiar with ACR TI-RADs to know which nodules to target for more images. Third, it's important to agree on a routine scanning and reporting process and to use it consistently. This applies, of course, not only to thyroid scanning, but it especially applies here. Also, it's important to agree on a reporting template and use it consistently, and Jenny will be returning to that in a little while. Finally, some practical points on how to use ACR TI-RADs in your practice. First, review prior scans to see what nodules were previously evaluated. This helps you home in on the same nodules on a subsequent scan. Second, it's valuable to do an overview scan. And again, it's important for the sonographers to know what to look for. So essentially start by scanning through the entire gland. In this case, we're just looking at the right lobe, but start with the entire gland and get the lay of the land, as it were. Decide what nodules look more suspicious, which less suspicious, and that will help determine which nodules warrant further imaging. It's also important not to obsess over features that have identical or very similar point values. For example, hyperechoic and isoechoic nodules have identical point scores. So you don't really have to spend a lot of time considering whether they're hyperechoic or isoechoic. Similarly, with lobulated or irregular margin, this is a lobulated nodule on the left and an irregular margin on the right. They both have the same point score of 2, so you don't have to spend a lot of time deciding which one applies in a given nodule. As well, even if the features are slightly different in point scores, if they're different by 1 point, for example, and applying one or the other doesn't change the TR level, you don't have to worry about that determination as much as you might otherwise would. Fourth tip, ACR TI-RAD says to formally report no more than 4 nodules with the highest point score that warrant FNA or follow-up ultrasound. You do not have to classify every nodule in the gland. That would be time-consuming and wasteful. Similarly, you can recommend FNA for no more than 2 nodules with the highest point scores that warrant FNA. Now, if you have several nodules that have identical point scores or are in the same in the same level, TR level, you can decide which one to recommend biopsy on using other criteria sometimes, such as size or where they are located in the gland. But generally, it's not productive to do a biopsy of more than 2 nodules in a given gland. On reporting, I give recommendations per ACR TI-RADS, but as I mentioned earlier, it's important to consider extenuating circumstances, including comorbidities and other factors such as family history or exposure to radiation. It's important never to say just that a nodule is amenable to biopsy, because every nodule is technically amenable to biopsy, at least almost all of them are, and it's incumbent on us to give recommendations. And finally, this is a question I receive often, you don't have to report the suspicion level. In fact, I never do, because patients see our reports and they will understandably wonder why a TR5 nodule is not being biopsied or followed. And finally, next steps will be continued evaluation of efficacy of our system, which I'm sure will be revised over time, looking at the role of elastography or contrast, and finally on an effort that I've embarked on recently, which is to organize an international symposium to try to harmonize ACR TI-RADs with other systems, because there's more commonality than there are differences between the systems. With that, thank you very much for your attention.
Thank you very much, Franklin. That was an excellent presentation. It really helped to clarify some of the practical points of view of how to get ACR TI-RADs into your practice. We're now going to hand the controls over to Dr. Bill Middleton, who is going to do the next section on imaging examples using ACR TI-RADs. Some people have sent in some questions already, which is great. Keep them coming in. We're going to collate them all at the end and answer them for you. I'll now give the control over to Dr. Bill Middleton. Thank you, Bill. Bill.
I'm sorry, I was still on mute. So,
you sound better.
And people may prefer that I be on mute. My kids often want me on mute. So I'm going to go over image analysis. The first thing that you have to do when you encounter a nodule is to measure it. And it's very important to use a consistent technique so that you can compare nodules over time. The technique that TI-RADS recommends is to measure the longitudinal axis on a sagittal view. When you look at your sagittal view, which is shown in the bottom left, you should mentally outline the nodule. So in this case, we have an ovoid nodule that is slightly off axis with respect to the long axis of the thyroid. You want to measure in the long axis of the nodule itself. So in this case, this measurement would be like this. On the transverse view, we measure both the long axis on the transverse view and the short axis on the transverse view. So 2 measurements are obtained on the transverse view. If we outline the nodule here on this transverse view, we can see that the long axis of the nodule is in this orientation. So that would be one measurement. And then you develop a line perpendicular to the long axis, and you move that line to the point where the nodule is maximum diameter. So this would be the second measurement in the transverse view. So one measurement on a longitudinal view and two measurements on the transverse view. Here's an example of a transverse view where the technique wasn't quite right. The long axis measurement here, the number one measurement, is probably done correctly, but the short axis measurement, number two, is not perpendicular to the long axis. So this would be better if the short axis were measured like this, and that would shave a couple of millimeters off of that result. Now let's move on to analyzing the different characters of the nodule. And the first, which Franklin mentioned, was composition. Composition is very important, and it should be the first thing that you think about. And it's divided into solid, mixed solid and cystic, and spongiform. So a solid nodule is defined as a nodule that is either completely solid or almost completely solid. And by almost completely, we mean greater than or equal to 95% solid. Those nodules get 2 points. Anything other than that is considered a mixed cystic and solid nodule, cystic or spongiform. So mixed cystic and solid gets 1 point. Purely cystic nodules get 0 points, and spongiform nodules also get 0 points. Spongiform nodules are nodules that have an appearance similar to the cut surface of a sponge, as you see in the lower right-hand corner. They consist of cystic spaces of variable sizes that occupy at least 50% of the volume of the nodule. And then in each category, there's a can't tell feature. And this occurs when you just can't figure out what the composition of the nodule is. Usually that's because there's so much shadowing from calcification. So this is a figure similar to the one that Franklin showed you earlier, and it comes from the SRU study that he mentioned. On all of these figures, the risk of cancer in percent is shown on the vertical axis, and then the point distribution is shown on the horizontal axis with the lower points to the left and the higher points to the right. And here you can see the solid nodules with the higher point value have a higher risk of malignancy than the mixed or the spongy nodules. Determining what is 95% can be somewhat difficult. This is a little exercise that I did for myself. Assuming that we had a nodule that was mostly solid and spherical, and within that nodule was a spherical cystic component. So if you image this nodule from slice to slice, you would see images that looked like this sequentially. As you pan through the solid component, you see just solid elements, and then as you pan through the cystic component, you see a cystic element. This is a nodule that's 95% solid. And this is an actual correlate. This is an ovoid nodule, where if you calculate the volume of the nodule itself, it's 5.2. Calculate the volume of this cyst, it's 0.27 cc's, and that results in a 5.2% cystic component. So in other words, a 95% solid component. So this type of nodule would be classified as solid or predominantly solid. Here's another nodule. This is almost entirely solid, although it does have a few little cystic spaces. And in cases like this, the cine clip is very helpful in having you kind of integrate the overall volume of cystic components. This, on the other hand, is a mixed solid and cystic component or nodule. It clearly has a predominance of solid elements within it, but there's enough cystic components that it clearly is not 95% solid. So this would be assigned 1 point and called mixed solid and cystic. This is a spongiform nodule. This is a nodule that is mixed solid and cystic, but the cystic components predominate throughout the nodule, and they vary in size, and they occupy more than 50% of the nodule volume. This is a spongiform nodule that has a lot of relatively large cystic areas. This next nodule is a spongiform nodule where the cystic components are variable in shape. If you look at the two static images above, you can see that there is a solid appearing component here that's less than 50%. And when you actually look at the cine clip, you can see that even that solid component has a lot of little cystic spaces in it. So this also is a spongiform nodule. Now in the can't tell category, these are nodules where you just can't tell the composition. And in this case, there's extensive calcification, mostly peripheral, and the shadow precludes determination of the composition. In this case, you give the nodule 2 points for composition. Now let's move on to another very important category, which is echogenicity. The echogenicity of the nodule should be compared with the ipsilateral thyroid or the strap muscles. If there's not enough normal thyroid on the ipsilateral side to compare, then you can compare to the contralateral side, but try not to do that unless absolutely necessary. Hyperechoic and isoechoic nodules are sort of self-explanatory, and they get 1 point. Realize that if the thyroid gland itself is hypoechoic due to autoimmune disease, you still compare the nodule to the hypoechoic thyroid tissue. Hypoechoic nodules are nodules that are less echogenic than the thyroid parenchyma, but are equal to or more echogenic than the strap muscles or the sternocleidomastoid muscle, and they get 2 points. Very hypoechoic nodules are less echogenic than the thyroid and less echogenic than the overlying musculature. They get 3 points, and if you can't tell the echogenicity, then you assign 1 point. So here's that same graph. You can see that as the point totals go up, the risk of malignancy goes up, and these are divided into solid nodules and into mixed solid and cystic nodules. So this is a nodule that is relatively close in echogenicity to the adjacent thyroid parenchyma. I think in this case, you could tell that this is slightly hyperechoic. Sometimes a good way to accomplish that when you're in doubt is to squint. When you squint, you kind of blur everything, and for whatever reason, it makes it a little bit easier to determine echogenicity. When you're squinting, just be sure don't close your eyes completely. That doesn't tend to work very well. So this is a hyperechoic nodule that gets assigned 1 point. This is another hyperechoic nodule. Now in this case, you don't see much thyroid parenchyma here, but on the transverse view, you can see some thyroid parenchyma that is abnormally hypoechoic because this patient has Hashimoto's disease. And you see the same thing here on the cine clip. So you compare to the thyroid parenchyma that you have, regardless of the echogenicity of the thyroid parenchyma. Here's a large nodule. There's really no adjacent thyroid parenchyma to visualize, so this would be hard to determine the echogenicity. In cases like this, it's very important that the sonographers find some place where they can display the nodule with adjacent normal parenchyma. And in this case, you can see there's a little bit of normal parenchyma in the upper pole that they have on the panoramic view, and the nodule is the same echogenicity as that normal parenchyma. Also remember, as Franklin mentioned earlier, when you have a mixed cystic and solid nodule, you determine echogenicity based on the solid, non-calcified part of the nodule. So if you looked at this overall nodule, you might be tempted to say it's hypoechoic, but when you really analyze the solid component here, it's the same echogenicity as the thyroid parenchyma. So this is an isoechoic nodule. Here's a hypoechoic nodule. Hypoechoic nodules get 2 points. And this is clearly less echogenic than the adjacent thyroid parenchyma, but it's more echogenic than the muscle. So this goes in the hypoechoic category. Also notice there's a lot of through transmission here behind this nodule. That is fairly common with thyroid nodules in general, and it does not mean that the nodule is cystic. If you're in doubt, whether a nodule is cystic or not, always try color Doppler. And if you see blood flow in it, like this, you know that it's not a cystic nodule. Now here's another nodule that would fall into the hypoechoic category. It is hypoechoic to the thyroid tissue, but it's isoechoic to the overlying strap muscle. You don't call a nodule very hypoechoic until it reaches this degree of hypoechogenicity, until it's actually less echogenic than the overlying musculature. And sometimes that's a little bit easier to determine if you turn your gain up just a little bit. It somehow makes the difference in echogenicity more prominent. So this is a nodule that's a little less echogenic than the overlying strap muscles. And here's another very hypoechoic nodule. You see here on the static image, this actually looks like it's cystic. It's that hypoechoic. It's about the same echogenicity as the adjacent common carotid artery. And you can see the marked hypoechogenicity here on the strap or on the cine clip. Again, notice that the vascularity here is extremely high, so that clearly is not a complex cystic nodule. Now, what about nodules where you can't tell? Here's another patient where there is so much calcification that you can't see what the composition, or in this case, what the echogenicity is. So this gets 1 point. And in this case, we ended up biopsy. You can see how calcified it is because the nodule moves with the needle rather than the needle moving through the nodule. The only reason that this was biopsied was because a node had been sampled while they were doing a lymphadenectomy for melanoma, and a node came back as positive for thyroid cancer. Next, we move on to margins. Margins are divided into ill-defined, smooth, irregular lobulated, and extrathyroidal extension. Ill-defined is determined when the nodule is just really difficult to distinguish from the adjacent thyroid parenchyma. That makes it difficult to make an outline of the nodule or to measure the nodule. That gets 0 points. Smooth is self-explanatory. That also gets 0 points. Irregular or lobulated refers to either large or small lobulations. Franklin showed you a couple of cases with relatively large lobulations. And irregular sometimes is referred to as spiculated or jagged. Those nodules get 2 points. If you see extrathyroidal extension, and that means you clearly see some of the, some of the nodule extending into the perithyroidal tissues, that gets 3 points. Now, you can't call extrathyroidal extension if there's just a bulge in the capsule. You have to actually see extension. A bulge in the capsule might indicate some extracapsular or extrathyroidal extension, but that's not necessarily the case. Again, you can see smooth nodules have a lower risk than lobulated or irregular nodules. Here's a nodule that's relatively isoechoic. That makes it hard to define the margins. So this would fall into the ill-defined category. Here's a nodule where the margins are very well demarcated. It's a nice round nodule. This would also get 0 points. This is a nodule that's irregular. If you look at the static image, you see all these little jagged spiculations extending into the adjacent thyroid parenchyma, also seen on that cine clip. And this is a nodule that's lobulated. You can see the lobulations on this border and over on this border on the transverse, and see them throughout on the on the other view. This is a nodule where you have clear cut extrathyroidal extension. There's a little piece of that nodule that's extending outside the margins of the thyroid, better seen on the cine clip here. And then finally, or next to last, is shape. Shape is determined on the transverse view, and this is where we refer to nodules being wider than tall or taller than wide. So wider than tall gets 0 points. And you occasionally will have nodules where the width is equivalent to the height. You can call those not taller than wide. they also get 0 points. If a nodule has AP dimension greater than the transverse dimension, that's called taller than wide, and those get 3 points. Those are basically nodules that are growing against the normal tissue planes. So here's a transverse view of a spongiform nodule. You can see that this dimension is bigger than this dimension. This is a wider than tall nodule, 0 points. Here's a nodule where the two dimensions are identical. So this is not wider than tall, but it's not taller than wide. So if it's not taller than wide, you assign 0 points. And then finally, these are two different patients with nodules that are both taller than wide. So this dimension in the AP direction is greater than in the transverse direction. Finally, we have echogenic foci or calcifications. And these are divided into comet tails, macro, peripheral, and punctate echogenic foci. So if there are no calcifications, 0 points. Comet tails are also 0 points, and that can only be diagnosed when the comet tail itself is greater than 1 millimeter. Macrocalcifications are defined as calcifications that are shadowing. If they don't shadow, it's not a macrocalcification. That gets 1 point. Peripheral calcifications can either be complete or partial. They get 2 points. And then punctate echogenic foci are small reflectors that have no shadowing and have either no comet tails or maybe occasionally a small comet tail. You can see how the risk of malignancy increases as the points for calcifications increase. Also notice that, as Franklin mentioned earlier, that you sometimes will have cases where there are different types of calcification. So for instance, this one has peripheral and macrocalcification. And notice that that combination there increases the risk of cancer above the risk for peripheral calcifications or macrocalcifications individually. This is a large comet tail, which we get 0 points. We see it right here, and we know that it's large because it's bigger than 1 millimeter. At this depth and this scale, this is 2.5 millimeters. So if you take that 2.5 millimeters and compare it to that comet tail, you can see that it's almost 2.5 millimeters, clearly more than 1 millimeter. On the other hand, this is a patient where there is a little comet tail associated with this nodule, but if you look at the scale, this is 1 millimeter here. This is a very magnified image. And when you compare the nodule to the scale, this is less than 1 millimeter. So this would fall under the punctate echogenic foci category. Macrocalcifications are calcifications that shadow. They're usually big and chunky like this. They get 1 point. Occasionally, you'll have a tiny little calcification, as we see here, that you'd be tempted to call a punctate echogenic focus, but if it shadows like this, then it falls into the macro category. These are peripheral calcifications. Peripheral calcifications can be very limited and partial, or they can be extensive and thick and completely encompass the circumference of the nodule. All of these would fall into the peripheral calcification category and receive 2 points. And then we get to punctate echogenic foci, or PEFs. This is a nodule that's lobulated and has all these tiny little echogenic foci scattered throughout, none of which have comet tails or shadowing. You can see it a little better on the cine clip. This is another nodule with punctate echogenic foci, just to give you a feel for that. And as I mentioned earlier, some nodules have more than one type of calcification. This nodule has some punctate echogenic foci as well as some shadowing macrocalcifications. So this gets 1 point for macrocalcs, 3 points for PEFs, so a total point total of 4. And that does it for image analysis. Thank you all very much for your attention. Jenny, you can take over at this point.
Right. Thank you so much, Bill. Beautiful imaging examples, crystal clear presentation, and we really appreciate the cine clips. But please, everybody, keep your eyes open, don't squint or close your eyes, as Bill suggested. So now with that, you might be wondering, how do I put this in practice? How do I start? And the first step is to use a structured reporting template. As I mentioned, I am running a multi-center study with a registry, and so I wanted to show you what template we're using for our study. This is a template, and all of this is for just one nodule. We'd be describing the nodule number, the maximum size, the other dimensions, and the location. Then this part is the 5 features, and it looks like a large piece of text, but remember these are pick lists, and so for composition you would just pick whether it was solid, almost completely solid. And here, as part of the structured reporting template, I thought this was a great idea to put in the points that it is worth, so you don't actually have to refer back to the chart each time. Then, after you've assessed the nodule for all of these 5 features, it's about adding the points up, and from the top part you can add up the points, and then based on the total points you choose a risk category, and once again the risk category pick list has the definition of the points it's worth. Then if your nodule has been imaged before, there are 3 questions to put into the report. Is there a change? And again, there's the definition of change in the structured reporting template. Whether there's a change in features, simply yes or no, and you may choose to describe it further, change in the risk category. And then finally, you give the TI-RAD's recommendation based on the risk category and the nodule size. Now, all of this is essential for a research registry because we need standardized data elements to collect the data. And for those of you who are not participating in research, you may be thinking, well, this is too long for my practice. It's really not practical to use something like this. Can't I just free text what I'm seeing and then refer to the chart? Well, let me show you a study that clearly shows that a structured reporting template like this with a checklist is very valuable. This is a study that is now in press in JACR. It was a study that was performed with private practice radiologists at Radiology Partners. And shout out to Radiology Partners there. This is a study that was performed in 3 phases. In phase 1, we simply used free text of their reports. In phase 2, 7 of these private practice radiologists were asked to use the TI-RAD's lexicon, so just describing the 5 features. And then in phase 3, this was when the TI-RAD's paper was published, and the radiologists were then given the structured reporting template again with the TI-RAD's risk category and the management recommendations. This is a graph that shows the management recommendations for each of those 3 phases, with the dark blue being phase 1 of just free text, the light blue being the structured reporting template without the recommendations, and the gray being a full ACR TI-RAD's structured reporting template, as you saw on that previous slide. As you can see, the number of biopsy recommendations for nodules recommended mentioned in the impression of the report did not change at all, and I was surprised with that result. But what did change were nodules that were mentioned in the impression of the report that simply had no recommendation at all. And without a definitive recommendation, which was the case in 1/3 of the nodules without ACR TI-RADs, then patients and the referrers were left with what to do. And many of these nodules may have been biopsied or followed up unnecessarily. What was also interesting in this study was the description of the features in phase 1 compared to phase 2 and 3. In phase 1, which was just free text, where radiologists were left to describe the nodule as they wished to, composition was mentioned the most, but still not all the time, and features that are important such as shape, margin, and echogenic foci were infrequently mentioned. With a structured reporting template and a checklist, in phase 3, all of these signs were mentioned for every nodule described in the impression of the report. Now, the next question is, just because it wasn't mentioned, maybe the feature wasn't there and it wasn't worth mentioning. Well, then we looked at the frequency of the suspicious findings, and we saw that tall and wide shape was not mentioned in free text, but it wasn't zero frequency. Up to 8% of those nodules had a taller than wide shape when there was a checklist to look to. And then same thing for suspicious margins. 1% had a suspicious margin where it was irregular or lobulated, but the frequency of a suspicious margin was much higher when the radiologists were prompted to use a structured reporting template and check off the margin. And so as a result, the average TI-RAD score in phase 1 was 3.1, which would make it a TI-RAD 3, but in phase 2 and 3, it was 4 as an average, which definitely makes it more suspicious. So the result of this is that the same number of biopsies were recommended when there was ACR TI-RADs. That's not because ACR TI-RADs recommended more nodules, but radiologists were seeing more of these suspicious findings when they had a checklist. Now, if you're interested in using that structured reporting template, the template is available on the ACR TI-RAD's website. Here is the URL to access that website. And on this website, you'll see other educational resources. We have the JSE publications, an atlas, and a structured reporting template also for nodule biopsies. The future webinars are here, so mark these on your calendar and sign up now so you'll get the reminders. The next one will be on case-based review and frequently answered questions, and I think that session is necessary because we don't have time to answer all the questions we've got today. And then the final webinar will be the evidence behind why to adopt ACR TI-RADs in comparison to other risk stratification systems. So now we reached the point where we're taking your questions. Once again, the URL for the ACR website is down the bottom for you to copy here. And let me take a look at the questions. I think I'll address the first question to Franklin. This comes from Daniel. And Carver also asked a similar question, as well as Tanman. Franklin, are you off mute?
I'm here.
Yes, okay. So the question is, what do you do with a TI-RADS 4 or a TI-RADS 5 nodule which don't meet the size criteria for biopsy or follow-up?
In those cases, I follow the recommendations as outlined in the white paper and we've discussed today. I say specifically that no FNA or follow-up is recommended. I understand that some people are uncomfortable doing that, but as Bill mentioned and as I mentioned earlier, in the intermediate category, say TR4, which is actually higher than intermediate, it's the almost the highest category, the risk of cancer is still fairly low. Even based on Bill's study, even at 6 points, the risk of cancer was less than 13%. And in the highest category, TR5, we're recommending follow-up of very small nodules. And at that level, what we're doing is very congruent with what other professional groups are recommending. I think it's really important here to get out of the mindset of having to identify and follow every cancer, because thyroid cancer biologically is not the same as breast or lung cancer or other aggressive malignancies. Okay. Bill, do you have anything to add to that?
No, I completely agree. You know, the problem with thyroid cancer is not underdiagnosis. The problem is overdiagnosis. Almost everybody agrees with that now. And there's a lot of thyroid cancers that that we're detecting that in the past would never have been detected and would never have been, symptomatic. So I don't think that people need to worry that much about missing these, small cancers. And by the way, many of these nodules in the categories that, that we're talking about will not be cancers. In fact, in the TR4 category, only at the most 1 out of 5 will be cancer, and it will, in most cases, it will be less than that.
Great. Bill, I have a question for you. It's about punctate echogenic foci. The question is from Claudia. What do you do with small echogenic foci that don't look like microcalcifications? And specifically on how do you distinguish them from tiny colloid calcifications? Do you ever struggle with that?
I struggle with that daily, and that's a great question. And I wish that there were a way to, reliably tell the difference between PEFs and little areas of crystalline colloid reliably. The pattern that I take is if I see them in cystic components of a mixed cystic and solid nodule, I don't worry about them. If I see them in solid components of a solid nodule or a mixed solid and cystic nodule, and there's not a long comet tail, then I assume that they're PEFs.
Okay, that's very helpful. Okay, Franklin, back to you. Do you ever use TI-RADs for pediatric patients? This is from Claudia. In our hospital, the endocrinologists mainly follow ATA recommendations for pediatric patients.
That's an excellent question. I've received it from some practitioners here at UAB as well. Formally, ACR TI-RADs only applies to the adult population. I think that for pediatric patients that are in the close to adult range, it's probably reasonable to apply ACR TI-RADs. But once you get to much younger patients who have a higher risk of cancer, I think that I wouldn't say that all bets are off, but you have to be much more careful about calling nodules, saying that they're benign or don't need follow-up based on ACR TI-RADs. And there are several publications in the literature that address how to manage pediatric patients with thyroid nodules.
Okay, great. Bill, this question is from you. It's from Jimmy. How do you classify margin for partially or mixed solid cystic nodules? Is the margin defined by the solid component, or do you take the solid cystic component?
Well, another good question. That sort of depends on the type of mixed cystic and solid nodule. So if it's that type of nodule that Franklin showed from the Korean paper, where there's a cyst with a mural nodule, then you analyze the margins of the mural nodule itself. So the mural nodule may have, lobulated borders that would, at least in the way that I do it, that would give them the 2 points for lobulations. For other cystic and solid nodules, you basically do it the same way as you do, for the solid nodules. You look at the periphery of the nodule and look for lobulations, which you occasionally will see with mixed cystic and solid nodules, or you look for irregularity, which is much less common with cystic and solid nodules.
Great, thank you. Well, I think that our time is up. We have so many more questions to answer, and as I mentioned before, we are going to address it in the next webinar. I thank you very much for your time, everybody that signed in and listened, and the people that are also listening after it's been recorded. It's great that you've taken the time to learn more about ACR TI-RADs, and we are definitely wanting to hear your thoughts. So email us at ACR, give us comments about how we can improve this, and sign up for the next webinars. Thank you very much, everybody. Thank you, Franklin. Thank you, Bill. And thank you, Lauren, for helping us organize this.
Thanks, everybody.
And thanks, Jenny.
Yes, absolutely.
Bye-bye, everybody. See you next time in April. Bye. Hi, everybody. Thank you for joining us today for the second ACR TI-RADS webinar. This is Beyond 101. We're going to be doing frequently asked questions, and a lot of those questions will be case-based. My name is Jenny Hong, and I'll be moderating and presenting. I'm a neuroradiologist at Duke University Medical Center. Our other speakers, Dr. Franklin Tesler, who is a professor of radiology at the University of Alabama, Birmingham, and Dr. Bill Middleton, who's a professor of radiology at Mallinckrodt Institute of Radiology. Both of us, all of us, are actually committee members of the ACR TI-RAD's steering committee, and Franklin was the chair of the committee. Now, our first webinar was on February 21st, and since then, we've been looking forward to this second one. Thank you so much to all the people that gave us positive feedbacks by email or on social media. From what we hear, we're really encouraged because it seems like we are really reaching out to you and really tailored the webinar to your needs. If you haven't listened to the first webinar, it's actually available on the ACR website, and here is the URL below. And if you think that you would like to see more webinars with ACR initiatives, please let us know and send us an email. Now, April is an extremely exciting month for us. If you're looking at our pictures here, we look pretty professional, but we're actually wearing party hats at the moment because this is actually the first year birthday of the ACR TI-RAD's white paper. It was online on April the 2nd, and so we're April the 4th today. And then the other exciting thing about April is that this issue of radiology is really the TI-RAD's issue. We have a paper from Franklin and Bill and Dr. Edward Grant, which is on the user's guide to ACR TI-RADs. It's everything they wanted to say that wasn't in the white paper. And a lot of it is covered in these webinars. And then we also have a scientific paper on how ACR TI-RADs makes a difference to radiologists across different practices. And we'll be speaking more about this in the next webinar. Now, onto the agenda. This is covering the questions that we received from you during the last webinar and also on email. We have identified 10 top questions that we want to cover first up in case anyone has to leave, and also to ensure and emphasize to you that they're key questions. And then after that, we've got the other questions, and then we're going to take questions from you. So a few housekeeping items. You can tweet about this webinar on AC with this hashtag, hashtag TI-RADs, and you can mention ACR, myself, or Franklin. Bill is not cool enough to be on Twitter at the moment. We will take your questions during the webinar, and so just type them in during the webinar and we'll collate them and take them all at the end. First, we want to hear about you. So we're doing a poll and the option screen is coming up. Select one of the following. Who are you? I am a radiologist, radiology trainee, physician who's not a radiologist, a sonographer, or other. And 90% of you are radiologists. Great. The next question is regarding your use of ACR TI-RADs. Does your practice currently use ACR TI-RADs? Yes, no, but will in the next 6 months, and no, not in the near future. Right, it sounds like everyone that's on this webinar will be thinking about using ACR TI-RADs, or they're using at the moment. That's great news. So now on to the questions. And I'm taking the first question. This is a question that prior to the last webinar, I also received multiple times by email. And the question is, what is the follow-up for TI-RADS 1 and 2 nodules? These are the benign and not suspicious nodules. And what is the management of TI-RADS 3, 4, or 5 nodules that are below the size threshold for follow-up and definitely below the size threshold for management? Well, here is the TI-RADS table, and you can see for TI-RADS 2 and 1 nodules, you don't do an FNA regardless of the size. For TI-RADS 3, if it's below the threshold, you don't receive any follow-up, and same for TI-RADS 4 and 5. Now, some of you are thinking, I'm calling a nodule TI-RADS 5 and it's 4 millimeters. So I'm really not going to do any follow-up or report it or biopsy it. And that makes people nervous, and I definitely get that. So in the next couple of slides, I'm going to tell you why we set these cutoffs of not doing anything and then how to report it. Does that sound good? So the rationale for ACR TI-RADS is that we want to identify nodules that are at high risk of malignancy and biopsy less benign looking nodules. And then of the nodules that are malignant, we want to target the ones that are going to be clinically significant. So what the ACR TI-RADS level does, 1 to 5, that's only based on the nodule features of the composition, the echogenicity, the margins, the shape, and the echogenic foci. There's nothing about size when it comes to the risk level. Then the chance that a nodule will be, if it was malignant, will be clinically significant. That is where the size comes in. Size does not predict malignancy. Size predicts whether the malignancy will be clinically significant. Now, of course, there are other features that predict whether the malignancy will be significant, and these are all part of the staging system, but we're assuming that you don't have any nodal metastases or distant metastases within your nodule. So let's start off with malignancy risk, and I've got a couple of slides that will hopefully convince you to let those nodules go. This is a table from Bill's paper in AJR that was published last year, where he took more than 3,400 nodules and put it through ACR TI-RADS. And in this study, there were many nodules, and he found that if it's TI-RADS 5, then it has a 35% chance of being malignant. TI-RADS 4, it was 9%, TI-RADS 3, about 5, TI-RADS 2, 1.5, and TI-RADS 1 is 0.3%. And now this was all based on just the features, not on size. Size does not predict the malignancy, and I'll emphasize that again. But size, what size does is it does affect survival. This is a table that shows the results of 10-year relative survival for more than 84,000 patients in the NCI SEER database. And there are two take-home points from looking at this table. First of all, the 10-year relative survival for thyroid cancer is really excellent. Now, this was for all histology types and all stages, all grouped together. The second key point to take away is that when a thyroid malignancy is less than 3 centimeters, the 10-year relative survival is almost 100%. And this is because so many of these cancers are small papillary cancers that are in the SEER database, because that is definitely the most common cancer. Then the other paper that talks about size is a paper that we published recently in Thyroid. This took the SEER database, and this time it was for 112,000 patients. This table shows the results of the effect of size on survival in a multivariate analysis. And the take-home point from this graph is that it's not until the nodule reaches, or the malignancy reaches 2.5 centimeters that the survival ends up becoming poorer and more than the baseline. This dotted line is the baseline. The further thing I want to say is that the ultrasound size is 5 millimeters larger than the pathologic tumor size, and all the patients in the SEER database, their size is based on the pathologic tumor size. So if we're saying 2.5 centimeters on this graph, we're really talking about 3 centimeters on thyroid ultrasound. So from these last two slides, does it mean that you should be only biopsying a thyroid nodule if it's 3 centimeters? Well, no, but it does mean that you can tolerate higher size thresholds than we're accustomed to tolerating, and particularly if the risk of malignancy is lower. That's what we've tried to do with ACR TI-RADs. We've tried to increase the size thresholds. Now, those that you particularly astute, you might be saying the SEER database is based on patients that have been treated for their thyroid cancers, and that is true. But there is actually a great body of evidence showing that even if untreated, these small thyroid cancers aren't actually harmful, and most of them are indolent. The first set of literature comes from active surveillance studies, which are mostly being performed in Japan. There was a recent one that was published in Thyroid by Oda, which took two groups of patients. All of them had small papillary thyroid cancers. In one group, they underwent active surveillance, and another group, they had immediate surgery for their small papillary thyroid cancers. These patients were observed for on an average of 4 years, and over that time, the people that had active surveillance, only 2% of them had enlargement of their malignancy, and only 0.5% developed new nodal metastases. The recurrence rate was the same between the active surveillance and the immediate surgery groups. No patients in either group had distant metastases, and no one died from thyroid cancer in either group. And because of this, these active surveillance programs are now being introduced in the United States. And then the other study that shows that thyroid cancer is incredibly indolent is an autopsy study. And this one was published in 1985. It took 101 patients that died from other causes. They thinly sectioned their thyroid and found incidental thyroid cancer in 36%. And these patients did not realize they had thyroid cancer in their lifetime. So it just shows that thyroid cancer is perhaps on the spectrum of normal. It's incredibly common, and it is indolent. You die from other causes. You don't die from it in most cases when they're small. So on to how to report. Well, my recommendation would be that you certainly don't need to use the full ACR TI-RAD structured reporting template that I showed you last time if the nodule is below the threshold for biopsy or follow-up. Now, the option is if you're not doing that, you can either not report or image and tell your sonographer not to image. You can image it, but don't report it. And then the third option is to just state in a sentence the TI-RADS level, the maximum size, and state that it doesn't meet the criteria for biopsy follow-up. Now, Franklin is going to take the next set of top questions.
Thank you, Jenny, and thanks to everybody for joining us this morning, afternoon, or evening, depending on where you happen to be. Start off with this set of questions. In the mixed cystic and solid nodule, does margin apply to the entire nodule or just the solid component? And does color Doppler help? Margin applies to the solid component of a mixed cystic and solid nodule, but eccentricity is important, as this image of Albert Einstein so ably demonstrates. The key point is to pay attention to the distribution of the solid components relative to the periphery of the nodule. I'll start off with a diagram showing an even distribution of solid material around the periphery of this mixed cystic and solid nodule. Most mixed nodules of this type really don't look like this because they start out as mostly solid and then undergo degeneration. So more often they look like this diagram, where they have what I call a roughly even distribution that may be irregular, thicker in some areas, thinner in others. Contrast that to this appearance of a mixed cystic and solid nodule with an eccentric distribution of the solid component. We would call this in other organs a mural nodule, and you see that the mural nodule here diagrammatically is irregular. But the key point is that it's eccentric compared to the periphery. Here's an example. This is from the how-to article that Jenny mentioned earlier from the current issue of Radiology. It's a mixed cystic and solid nodule with solid components around its periphery, relatively smooth and even in appearance. Contrast that to this cancer, which shows a mixed nodule with this lobulated solid component that you see multiple irregularities or lobulations along its margin, protruding into the nodule eccentrically. This also has multiple punctate echogenic foci within it. The same is true of this example from the literature. There have been several papers over the past few years dealing with this type of nodule, and all of them talk about the eccentric appearance, the lobulation of the solid component, and they also point out the punctate echogenic foci that we see here as an important sign. What about color Doppler? Color Doppler can be helpful to distinguish tissue from schmutz. And for those of you not familiar with that word, it's a Yiddish term that means dirt. And I'm referring to here to non-specific, non-tissue material within thyroid nodules. If you see flow, that means you're dealing with living tissue, as in this nodule on the left. Lack of flow, however, doesn't always mean that you're dealing with necrotic tissue or debris. On the other hand, layering, as illustrated on this nodule on the right, the arrows are pointing to layering material. That refers to debris that you don't have to be concerned about. Next question, should a nodule suspicion level be reported? This is a very frequent question that I've received from people in multiple places, so I'll deal with my perspective on it. Here's the relevant part of the ACR TI-RADS chart. My answer to this is it's really up to you, but I usually don't report suspicion levels. Here you see that going from TR1, TR2, 3, 4, and 5, you have different points associated with each one, but you also have the descriptors that the ACR TI-RADS committee apply to each one, going from benign, not suspicious, all the way up to highly suspicious. I think that those terms were appropriate relative to one another. However, the reason that I usually don't report suspicion level is that referring physicians and especially patients may wonder about highly suspicious nodules that are not being biopsied or in some cases not being followed, as Jenny referred to earlier. One option would be to refer to numeric risk ranges. This is a part of the same figure that Jenny showed earlier from Bill Middleton's article in AJR, showing that as you go up in points, what the risks of malignancy are. And you can certainly choose to report these, but I think that could be misleading as well. That's because the risk or probability of malignancy is not the same as the risk or probability of harm to the patient. As Jenny mentioned earlier, thyroid cancer is different. So a risky nodule or a risky lesion in some other organ, say the lung or breast, is different as far as harm to the patient goes compared to a nodule in the thyroid gland. Next question. Because punctate echogenic foci, or PEFs, are awarded 3 points, what can be done to avoid overcalling them? And how should linear echogenic foci be reported? It used to be thought that these echogenic foci mostly represented so-called Samoma bodies, also known as calcospheroids, which are really small, 0.07 millimeters. I don't know that our ultrasound machines can really see them down to that level, but they often occur either in clumps, and we may be seeing clumps of them in many cases. Here's an individual calcospheroid or Samoma body, and you see the typical lamellated appearance with this concentric configuration that they show under the microscope. Mike Bieland and co-workers published a very interesting article on punctate echogenic foci several years ago in the Journal of Ultrasound and Medicine, and they classified them into 4 categories shown here. The 2 at the top, including larger ones with comet tail artifacts, which we recognize as colloid, and the linear ones that you see in the top right, were benign. The small and even smaller punctate echogenic foci, which tend to be 1 millimeter or less and non-shadowing, tended to be malignant. And these 2 on the bottom are the types that we're looking for. However, the association between them and psammoma bodies is not as strong as we used to think. In this article from the group at Stanford in 2016, it was shown that only 45 to 48% there was a positive predictive value of that low for psammoma bodies. That is, most of these punctate echogenic foci, the small ones, were not psammomatous calcifications. And here's an example from that article showing a papillary thyroid cancer with multiple small echogenic foci that I'm pointing out here that we would certainly call PEFs, but none of those turned out to be psammoma bodies. In fact, some of them, or many of them, were coarse calcifications. Here's some examples from my experience. This is a proven papillary thyroid cancer, and you see throughout it multiple echogenic foci of varying size. Some of them look like they have comet tail artifacts, but it's possible that many of these are not psammoma bodies, although on pathology, this did have some psammomatous calcification. Here's another example. This is from an 11-year-old patient, and you can see scattered small punctate echogenic foci throughout this nodule. Again, many of these may not be true psammomatous calcifications. And finally, this is a nodal metastasis from a patient with papillary thyroid cancer showing a few scattered punctate echogenic foci coming into and out of the field of view. Those are the abnormalities that we're looking for. However, it's important to distinguish true punctate echogenic foci from speckle, which is the pattern that we see in parenchymal organs like the thyroid that mostly results from interference, and non-specific, what I call dots and dashes. These are 2 normal or near normal thyroid glands, and you can see that I'm pointing to small dots and sometimes linear echogenic foci throughout. These are normal and should not be mischaracterized as punctate echogenic foci. So before calling them in a given nodule, I look at the adjacent parenchyma or the parenchyma elsewhere in the gland, and I make sure that they're really confined to the nodule and they're well-defined and rounded. Next question, if there are more than 4 nodules, should the sonographers take images of all of them? If not, how do they know which ones to image? Are there exceptions? I have 2 sets of guidelines on this for you. One, if there are no prior studies. I always start with overview images, and clips are better if you can do them to show the entire gland, sagittally and axially. The sonographer should take images of and measure and annotate the nodules that are most likely to need FNA or follow-up. In order to do that, they need to know ACR TI-RADs, which is why we have the ACR TI-RADs chart in all our scanning rooms. And we formally report or score up to 4. Very, very rarely do I ever report more than 4. In fact, I don't remember ever having to do that since adopting ACR TI-RADs. This clip shows the value of an overview scan. It gives you an idea before you start measuring or annotating anything which nodules to focus on. My guidelines for prior studies are slightly different. It's important to review priors, whether it's ultrasound, CT, MR, PET, or radionuclide studies, to see which nodules to assess. The exception is pre-ACR TI-RADs ultrasound. In other words, if you used to be in a practice, or you are in a practice that used to measure every nodule, there's no need to continue doing that in the ACR TI-RADs level. Again, begin with overview scans and measure and annotate and image the nodules that were noted on priors are most likely to need FNA or follow-up. So for example, if you have a PET scan that shows something that's FDG positive, you definitely need to report that on your ultrasound if there's a corresponding nodule. If there's a CT that shows a nodule, you need to report that on your current ultrasound scan, even though it may not warrant FNA or follow-up. And that's to answer the clinical question that for which the ultrasound was ordered. And again, I very, very rarely, or in my case so far, never report more than 4 nodules in a gland. Should ACR TI-RADs be used in pediatric patients? The answer is technically no, but a nodule that's suspicious in an adult is even more suspicious in a child. I refer you to this article in Radiographics from last year, and you'll notice in the first bullet point that they say that individual thyroid nodules in a pediatric patient has a 3 to 5 times greater risk of malignancy than in an adult. And now I'll pass on control to Dr. Middleton.
Thanks, Franklin, and thanks to everybody that's joining us today. We have a few more questions to get through. The first one that I was assigned to tackle was, how do we distinguish spongiform nodules from mixed cystic and solid nodules, or solid nodules with minimal cystic components? Well, first of all, we need to go back to the definition of a spongiform nodule. So they are defined as a nodule that's composed predominantly, meaning greater than 50%, of tiny cystic spaces. So they should all be predominantly cystic in composition. Now, it's okay to have larger cystic spaces within a spongiform nodule. That doesn't negate the fact that it's cystic or that it's spongiform. So if you look at this nodule here in the lower left-hand corner, this is a classic spongiform nodule. It's predominantly cystic, multiple tiny little spaces, and a lot of septations kind of separating those cystic components, but very minimal solid component here. If there are larger solid components, then you have to put it into the mixed cystic or solid category. So these are two mixed solid and cystic nodules. Note that this nodule is relatively similar to this spongiform nodule. It has a lot of small cystic spaces in it, but there's just a considerably larger amount of solid material. So this would be better classified as mixed solid and cystic. Same thing for this nodule on the right. There is a lot of cystic spaces and multiple scattered little cystic components, but there's just too much solid material here to call it spongiform. Mixed solid and cystic nodules, in distinction from spongiform nodules, tend to appear in sort of 4 discrete categories. So many of them, I would say most of them, are solid with scattered cystic spaces, and that's what we're seeing here. They can also be cystic with thick or irregular septations. That's what we're seeing here. They can be cystic with thick walls. Franklin showed an example of that earlier. Or they can be cystic with mural nodules, and Franklin showed examples of those earlier, similar to this one. That's what you typically see with mixed cystic and solid nodules. Now, the question was, how do you tell the difference? And sometimes the reason that you're having a hard time telling the difference is that you're having a hard time getting a good look at the nodule. And for the sonographers that are in the audience, you all know that there's a trade-off between penetration and resolution. And in each nodule that you evaluate, you want to make sure that you use the transducer that will give you the needed penetration as well as the highest possible resolution. So that will depend on the depth of the nodule and the thickness and composition of the soft tissues in the neck. And then it's also important to take cine clips on nodules where the composition is difficult to determine from static images. This is an example where we can see this nodule. There certainly are spongiform components to it here around this periphery, but there's a substantial solid component as well. And you might have trouble deciding where to place a nodule like this. When you look at the cine clip, I think it's pretty clear that the solid components are relatively minor compared to the cystic components. And this is one that I would have called a spongiform nodule. Next question, what are the exceptions to ACR TI-RADs? Well, there are a number of exceptions. Some that sort of apply to a broad category of patients are listed down below here. So patients with clinical risk factors, such as MEN type 2, radiation in childhood, family history, those sorts of things. Sometimes you need to make an exception because of referrer or patient preference. And sometimes advanced age or significant comorbidities will change how you approach a nodule. But these are the cases in this box that I want to highlight individually. So the first is FDG positive nodules. This is an example of a 63-year-old man with an invasive pituitary microadenoma. He had a PET scan that showed an FDG avid thyroid nodule in the right lobe of the thyroid. So he came to ultrasound, and you can see that he has scattered similar appearing nodules, the largest of which was about 8.5 millimeters. It's solid and hypoechoic, 4 points, so it's a TR4 nodule, and under normal circumstances, a nodule with this size and this TI-RADS level would be followed at 1, 2, 3, and 5 years. But because of the positive PET scan, this is a nodule that really should be aspirated for a couple of reasons. One is most of the time the management will change depending on whether it's a thyroid cancer or metastatic disease to the thyroid. And there is data that shows that cancers that are FDG positive have a worse prognosis. This is another example of a patient that just came in with a history of a thyroid nodule. We didn't really know much else about this patient at the time. And you can see when you look at the static image and the cine clip, it's solid, it's hypoechoic, it's got a macrocalcification and a PEF. So this is a TR5 nodule, but it's less than a centimeter. So it doesn't meet criteria for FNA, it meets criteria for yearly follow-up. However, in this patient, there's also a suspicious lymph node. This is a right level 3 lymph node that has cystic areas and a few little bright foci, very suspicious for metastatic disease. And in a case like this, the nodule and in many instances, the lymph node should also be aspirated. This is a 41-year-old woman who had a left thyroid nodule seen on a CT scan. Referred to ultrasound, you can see the images here on the left. It was a 1.2 centimeter nodule, it was solid, very hypoechoic, that's 5 points, so it's a TR4. That would meet criteria for follow-up, but not for FNA. However, look at the location of this nodule. It's posterior in the thyroid, and it's immediately adjacent to the esophagus. If you look at this diagram, you can see where the recurrent laryngeal nerves are. They're right next to the esophagus in the sort of groove between the trachea and the esophagus and the thyroid in the esophagus. So nodules that are in this location are at increased risk of involving the recurrent laryngeal nerve. If the nodule enlarges just a small amount, that's going to put this patient at increased risk of surgical complications and increased risk of postoperative morbidity. So in this particular location, it's important to be more aggressive. And in this case, an FNA is probably necessary to confirm, first of all, that it is a malignancy, and then perhaps to be more aggressive in approaching your follow-up or referring to surgery. This is a 58-year-old woman with hyperparathyroidism. When doing the scan to look for a parathyroid adenoma, we found this small nodule, measured a maximum of 7 millimeters. It's solid, hypoechoic, and has PEFs, so that's a TR5 nodule. But because it's less than a centimeter, it doesn't meet guidelines for FNA, it meets guidelines for yearly follow-up. However, this patient has hyperparathyroidism. Here's the parathyroid adenoma. This patient's going to the operating room anyway to deal with the parathyroid adenoma, and there's no reason to ignore the thyroid cancer when you're already in the operating room dealing with thyroid and parathyroid tissues. So this is one that really needs to be FNA'd, and if it does in fact turn out to be cancer, then the surgeon would do the appropriate surgery at the time of the parathyroidectomy. This is a 58-year-old woman with neck pain, so symptomatic nodule rather than an asymptomatic nodule. If you look at these scans, they're scattered, poorly defined hypoechoic regions within the thyroid, the largest of which measured 19 millimeters. They were solid, very hypoechoic TR4 nodules. Normally, this would meet criteria for FNA, 1.9 centimeters and a TR4 nodule. But this patient has neck pain that was very suggestive of subacute thyroiditis. And the ultrasound images are also very suggestive of subacute thyroiditis. So in a case like this, it's appropriate not to do the FNA, but to do follow-up scans instead. And these follow-up scans showed that things did resolve on their own. Here's a 50-year-old woman with a prior history of FNA of a right-sided nodule that was benign. Now she comes in with this nodule seen. It's solid, very hypoechoic, has PEFs, 8 points. It's a TR5 nodule, and it measured a maximum of 1 centimeters. So normally this would meet our criteria for FNA, just barely, but it would meet that criteria. But when you look back through the old records and the old images, you see that this is what this nodule looked like when it was initially seen and initially aspirated. This is a complex cyst that's just involuted over time and has become a suspicious-looking solid nodule. This is a phenomenon that's called mummification of cysts or involution of cysts, and it's a thing that you should be familiar with, because in a case like this, you certainly would not want to repeat the FNA. Next question. How should we determine echogenicity, especially distinguishing ISO from hypoechoic nodules? Well, let's go back to our ways of defining and classifying echogenicity. First of all, remember that you compare it to the thyroid and to the strap muscles, and you only evaluate the solid, non-calcified portions of the nodule. So here are two different nodules. They're both hypoechoic to the thyroid. This one on the left is also hypoechoic to the, or greater in echogenicity than the muscle. This one on the right is equal to the muscle. Both of these would satisfy our criteria for a hypoechoic nodule. They don't get defined as very hypoechoic until they're less echogenic than the muscle. So these would both be hypoechoic and awarded 2 points. Then the next question is, how do you optimize the image to distinguish the echogenicity of a nodule? And again, you need to use the appropriate transducer and obtain cine clips when necessary. Here's an example of a patient where we have a nodule and there's peripheral calcification that is causing a fair amount of shadowing. In this case, you probably would have to say you can't tell what the echogenicity is and assign 1 point. But when you switch your probes from a higher frequency probe operating at 15 megahertz to a lower frequency probe operating at 8.4 megahertz, you can see that the penetration is improved. You can see the internal characteristics of that nodule. It's hypoechoic, so it gets 2 points instead of 1. And in fact, you see a few little PEFs here as well. So it would get an additional 3 points. So optimization of the image is very important, especially to the sonographers out there. Now, specifically in distinguishing isoechoic from hypoechoic, there are some tricks that you can use. This is the image that was originally taken of this nodule, and it looks like it probably is a little hypoechoic to the surrounding parenchyma, but it's a close call. If you increase the gain, sometimes that helps, and I think it's a little bit more obvious here that this is a hypoechoic nodule. You can also adjust the dynamic range, and generally you want the dynamic range to go down, which will give you more image contrast. And in this case, that made it, obvious that this was a hypoechoic nodule and not an isoechoic nodule. It's also important to distinguish hypoechoic nodules, which get 2 points, from very hypoechoic nodules, which get 3 points. And those same techniques can help in this situation. This was the original image. You can see that this is pretty close to the same echogenicity as the strap muscle. Hard to know if this is hypo or very hypo, but when we increase the gain, everything gets brighter, but the strap muscle gets brighter to a greater extent, and this is, in this case, a very hypoechoic nodule. Next question. If a nodule is truly round, in other words, not wider than tall and not taller than wide, how should it be scored? And the simple answer is it should be reported as not taller than wide, and it should be assigned 4 points. So a nodule like this, where the AP and transverse diameter are identical, this would be reported as not taller than wide. But that brings up the question, what do you do with spherical nodules? And do they really not have an increased risk of malignancy compared to ovoid nodules? And there hasn't been a whole lot of study that has looked specifically at that. When I got this question, I looked back at the SRU database and specifically looked at nodules that were spherical. And I defined those as the maximum diameter was within 1 millimeter of the minimum diameter. And if we just looked at nodules greater than a centimeter, then of all spherical nodules, 18% were malignant. Of nodules that weren't spherical, the malignancy rate was much lower. Malignant nodules were spherical in 4.5% of cases, and benign nodules were spherical in 1.9% of cases. Now, this is a very selected group of patients, and there's a lot of biases in this analysis. But it is possible that in the future, we may end up giving more than 0 points for nodules that are spherical. So that takes care of all of our 10 most common frequently asked questions. We do have time left to cover some other frequently asked questions. And this was the first one that I was assigned. Is there a size below which a nodule cannot be accurately characterized? And the answer to that is yes, but it depends on a couple of things. First of all, it depends on the nodule's composition. So pure cysts can be, accurately characterized as cystic when they're very small, down to 2 to 3 millimeters. But mixed solid and cystic nodules and purely solid nodules are a little bit harder to characterize when they're less than 5 millimeters. It also depends on the thickness and the composition of the tissues in the neck. So patients with short, thick, fatty necks, generally it's hard to characterize lesions that are less than 5 millimeters, and sometimes hard to characterize lesions even larger than that. But in your skinny patients with long necks and little fat, even solid nodules can be characterized when they're 2 to 3 millimeters. Fortunately, we almost never recommend follow-up or FNA for nodules that are less than 5 millimeters. And then the next question, what should be done if a nodule changes and receives a follow-up score that's higher than the scores of previously followed nodules? So this is assuming that you've got a previous exam that's been scored by TI-RADs. And my answer to that is, if you're previously following 3 or fewer nodules and you have a new nodule that's got a higher score than those 3, then you just add it to your recommendations. But if you've previously been following 4 nodules, then you have to replace the nodule with the lowest score with the new nodule with the higher score. You continue to just follow the 4 nodules with the highest score. And then finally, how should we handle patients who had an ultrasound that was done prior to ACR TI-RADs and may have had more than 4 nodules followed? Well, first of all, I feel sorry for you that you're following more than 4 nodules, and that's one of the reasons why the TI-RADs system, put a limit of 4. But basically, you just start over again, and you determine which of the nodules have the 4 highest scores, and you follow the recommendations for those nodules. In many cases, you'll end up following less than 4 nodules. And if you're lucky, and if the patient and the referring physician are lucky, you won't have to follow any of those nodules that were previously followed prior to TI-RADs. Okay, so that does it for all of my frequently and less frequently asked questions. I'm going to turn the controls back over to Franklin, and he's going to include a few more of the asked questions.
Thank you, Bill. And let's see if I can, there we go. There we go. In determining management, should the nodule's largest measurement or an average of all three measurements be used? That's an easy one. It's the largest measurement that determines management. What should we report for previously biopsied nodules? This is a fairly frequent question. And we said in the white paper that management is usually going to be based on the referring practitioner's request. This, which is going to be based on what the previous biopsy showed. There's a chart actually that's missing from this slide from the latest ATA guidelines, but basically it showed the 6 categories in the Bethesda classification. And often you won't know what the last biopsy was. You may know that it was benign. You may not know if it was an intermediate category. So generally, request for further management of those will be based on information that the referring practitioner has. What if there are 2 nodules with the same TR level? One meets the size criteria for FRNA, but the other doesn't. What recommendations should be provided? Here, we follow the chart recommendations for any TR level. So for example, if you have a TR3 level, one of which is 3 centimeters and the other is 1 centimeter, the larger nodule will warrant FNA and the smaller nodule will not even require follow-up. So it's just basically a matter of following the chart. That's it for my additional questions. And I'll pass control on now.
Well, it's me again, Jenny. Thank you, Bill and Franklin, for such fantastic presentations. Enjoyed learning more Yiddish. And Bill, that case of mummification was fantastic. I think I have control now. My less commonly asked questions are, is ACR TI-RADS an accepted standard? And the answer is no. It's a white paper. It's guidance. It doesn't even meet the criteria of guidelines as required by the National Guidelines Clearinghouse. But it was developed under the auspices of ACR, and it is evidence-based to the greatest extent that we have it. Franklin did a fantastic job of leading the committee, as I've mentioned before. And compared to many other committees I've been on, we had multiple conference calls, as I mentioned, very long emails from Franklin and other members. And Franklin even implemented multiple surveys so that our final product was really based on consensus. And then Bill applied the SRU database to what we came up with ACR TI-RADS. So it's not an accepted standard, but it's a very, very good one. The other question, which I've heard before for other topics, is should reports include a disclaimer stating that some cancers may be missed? And I'd say no to that. But definitely you should be try to be definitive as much as possible with your reports. And I lecture about this at another situation. Then why not give an overall ACR TI-RADS score to the thyroid rather than individual nodules? And I think this comes from people that are very familiar with BI-RADS and like one overall score. Well, for ACR TI-RADS, it doesn't quite work that way because we're not evaluating the thyroid gland as a whole on one image or 2 images, as with mammography. We're evaluating a thyroid which often has more than 1 thyroid nodule. So to give an overall score based on an average of the nodules or the most suspicious nodule really doesn't explain the whole picture, and it is best applied to individual nodules within the gland, and as we've said again, up to 4 nodules only. The other question was, can ACR TI-RAD's structured report be, where can it be found? It can be found on this website here. You can also just Google ACR TI-RADs, and this will probably be the first thing that comes up. And on this website, we have a short introduction to what the goals of ACR TI-RADs are. Here you can see the last webinar is already there as a video. This is takes you to a YouTube link. We've got how to sign up for the next webinar here. The last one will be on the evidence behind ACR TI-RADs. And then we've got links to all the articles that members of our committee have published on ACR TI-RADs. And then at the bottom, we have some tools on the template, a small atlas, and then a sonographer's worksheet. So just Google ACR TI-RADs and you'll get to that. And here are some examples of the resources. So we have a couple minutes left, and I want to draw your attention to the next webinar, which will be on May the 30th. Which will be the final one, and it's evidence behind the performance. As I mentioned, we are celebrating the 1-year anniversary of ACR TI-RADs. So we have since then published several papers on the evidence behind ACR TI-RADs, and there are other people outside the committee that have done that too. So we hope to put it all together and show you how ACR TI-RADs does as a whole, how it does to radiologists' previous practice, and how it does compared to other guidelines out there, such as the ATA and the Korean and French TI-RADs. And the most common question we got from the last webinar was this one: will this recording be available after the webinar? And the answer is yes, this one and the prior one and the next one. For more questions, email rads@acr.org. In particular, I would be really interested to hear from you your initial experience for the people that have started using ACR TI-RADs. Is it taking longer? How long did it take before your radiologist got familiar with it? Do you like it? And I, as a PI of the registry study, I've definitely heard mixed responses. But overall, what I've heard is that for each individual nodule, it does take longer to apply 5 categories to the nodule, but because I'm not reporting as many nodules, it probably takes about the same amount of time, but I know I'm doing a better job and patients are getting more standardized reports and recommendations. So we have a couple minutes and we're on to your questions. So far, I haven't received any questions, and I also like to take this opportunity to thank Lauren Hicks, who has been working behind the scenes to deal with our multiple versions of presentations and getting us organized and helping with the publicity of these webinars. Thank you so much, Lauren, for your work. So there are no questions. Franklin and Bill, do you have any comments that you've heard about people adopting ACR TI-RADs, whether they've struggled, whether people have been on board, whether they've adopted and then reversed back?
I'll take this. This is Franklin. I haven't heard anybody who's done any backsliding. I have heard from several people that it was harder than they thought it was going to be. Mm-hmm. So I think you have to devote the time and be patient. In practices where the sonographers do the majority of the imaging and then radiologists do the interpretation, you have to take the time to allow the sonographers to learn the system and know what images that they need to take. So for example, if they scan a gland and take images of and annotate 10 nodules like they may have been used to, that makes it harder for the interpreting radiologist, who then has to pick which 4 nodules or fewer perhaps to actually report. It takes, you have to give it time for that to happen. But once you get going, I think I agree with what you just said. I find I'm working more quickly than I used to, and I'm certainly more consistent. And the radiologists across our practice here are more consistent with each other than they used to be.
Okay, yeah, great. Yes, certainly the educational component is really key, and I would recommend to the listeners that you forward the links to the webinars for your sonographers and your radiologists. It is a really very concise way to get up to speed with ACR TI-RADs. Bill, I have a question for you that's come from the audience. What does one do with a known malignant nodule, i.e. BI-RAD 6? How would you report it?
Now, I'm sorry, say that again, Jenny?
How would you report
TI-RAD 6?
Well, how would you report a nodule, a thyroid nodule that is known to be malignant?
That you're actively surveilling?
Yeah.
So the most important thing there is to document size changes and to document the presence or absence of any suspicious, cervical lymph nodes.
Right.
In both of those cases, then the patient would probably end up going to surgery.
Yeah. So this is a case that's really similar to the active surveillance programs in Japan. If there's a change in size or if there are new nodal metastases, then that would be a point where you draw the attention to it and say that it's progressed, and those patients would more likely get surgery. And also any invasion outside the capsule, if that's been a change as well, that's really important. The other question I'm going to pass on to Franklin. Is there a specific definition for a multinodular goiter in TI-RADs? Do you assign a TI-RADs category to these nodules?
There is no specific definition for a multinodular goiter, although I hear that term misused fairly frequently. Goiter simply refers to an enlarged thyroid gland. I use the term multinodular goiter when the gland is overall enlarged and there are multiple nodules that are causing that enlargement. That is, if you have an enlarged gland that is basically normal in echo texture and has multiple nodules that are small, I wouldn't call that a multinodular goiter. What I do in those cases is I look for any nodule that stands out by virtue of its ACR TI-RADS classification. If there are multiple nodules that are similar and relatively low in suspicion, say TR3, and they're scattered throughout the gland, I typically just recommend follow-up for those. I don't think there is any value for just biopsying the largest nodule simply because it's larger than others. The problem in glands like that is that there is a lot of room for sampling variation if you how do you pick which one to biopsy? And again, the way to do that is how it compares to the other nodules in the gland. But I understand those are difficult to deal with. In fact, those glands make it really hard to measure nodules because they're often confluent and it's difficult to see their borders.
Right, great. Well, we don't have any other questions, but I will say that, Franklin, I really enjoyed that slide where you said we're looking at the probability of malignancy and then also the probability of harm. And that is a particularly good point to emphasize when we're not doing follow-up or biopsy for small nodules and we're choosing not to use these terms of highly suspicious, moderately suspicious, so that we're not alarming patients. And I think that that's the end of the webinar. If no one else has any questions, I'm going to take you back to the original slide, which gives you the link to the resources, the ACR webpage, and it's constantly being updated. I think what we'll do is we'll see if we can list all these questions out and maybe give you a time in which it is present on the video so that you can go back and refer to specific questions or refer other people to these specific questions. Franklin, Bill, do you have any other comments in our last minute?
One last comment. We know that ACR TI-RADS is far from perfect. So if anybody out there has any specific recommendations for improvement, please pass them on to me or anybody else on the committee, and we'll take those into account as we consider revisions in the future.
Okay, great. Bill?
Nope.
Nope. Okay, thank you.
No additional comments.
Thank you, everybody. Thank you for tuning in, and we hope to see you on May the 30th at 1 p.m. Eastern Time for the final chapter of the ACR TI-RADS webinar. And please send in your comments. We love getting fan mail, and we also like to hear constructive feedback as well. So thanks for reaching out to us, and like us and subscribe to us on YouTube. I've always wanted to say that. Thank you.
Bye, everybody.
Bye, everybody.
Bye.
Hello, everybody. Welcome to this ACR TI-RADS webinar part 3, Why Adopt ACR TI-RADS Evidence Behind the Performance. My name is Dr. Jenny Hong, and I'm a neuroradiologist at Duke University. Well, this is our final webinar. We've come with a box of tissues each, and this follows a webinar first on how we do it. So that was the how of ACR TI-RADS. Then we had a webinar of commonly asked questions, and that was really more of the how, but also the what, the where, the when, and even the who of ACR TI-RADS. And now with this final webinar, we're going to be talking about why. Why should you consider adopting ACR TI-RADS and continue to use it? We are going to be reviewing some key articles here, and we're going to help you interpret them. And what we want you to get out of it is really for you to understand why you should be spending the extra time to change your practice and use ACR TI-RADS, and if it is time well spent. I'm going to be introducing you to our other speakers. We've got Franklin Tesler, who's a professor of radiology at the University of Alabama in Birmingham, and he was the chair of the ACR TI-RADS steering committee. He continues to lead efforts on the international front, and he'll tell you more about that later on. We've also got Dr. Bill Middleton, who's a professor of radiology at Mallinckrodt Institute of Radiology, and he was a key member of the ACR TI-RADS steering committee, and it was really his data that helped us make decisions on the ACR TI-RADS model. And then there's me. I'm passionate about improving patient care directly day to day, but also through research and education, and I've really enjoyed being a voice on these ACR TI-RAD committees. All three of us, now that we're on our final webinar, I'll have to tell you, are really very passionate and generally care about everyone adopting better practice for thyroid nodules. And we want you to be better armed with adopting ACR TI-RADS if you choose to do so. And this is why we've devoted our time to putting all this together for everybody and answering questions when we get them. Now, one might think that a webinar on the evidence might be somewhat dry, but we have thought really hard about the format, and rather than presenting article after article, we've divided up the literature into just simple questions that you may wonder. So I'm going to tackle the first question of why to adopt ACR TI-RADS. Then we'll have Franklin, who will be talking about ACR TI-RADS features that are particularly challenging. He'll also talk about the differences between ACR TI-RADS versus ATA and SRU. And he'll also talk about the size thresholds and the rationale behind that for ACR TI-RADS and why it's different to the others. He'll touch on the question of why ACR TI-RADS and ATA could or could not be used simultaneously. And then after that, Bill has a very big task of giving you some review of comparing ACR TI-RADS to other risk stratifications, and that's through the work that he's done as well as some literature that's come out recently. And then finally, we'll talk about future plans for ACR TI-RADS. I hope that you can stay for the full hour, and thank you for attending, everybody. This session will be recorded and made available anytime afterwards, as were webinars 1 and 2. These are available on the ACR TI-RADS website. So first we have questions about you. Who are you? Are you a radiologist, a radiology trainee, physician, sonographer, patient, or other? And you can answer the questions on the GoToWebinar panel. And it seems that most people are radiologists, but thank you to the trainees and physicians and sonographers that have channeled in. The next question is, Does your practice currently use ACR TI-RADs? Yes, no, but will be in the next 6 months, and no in the near future. No, not in the near future. And it seems that the majority of people will be using ACR TI-RADs or have been using ACR TI-RADs. That's great. And for the others, maybe we can convince you. Okay, so my section is why adopt ACR TI-RADs. And let me start off with a sample report that I received from a colleague of mine who is an interventional radiologist. This is his sister's radiology report for her thyroid ultrasound. And she's an attorney who had no palpable nodule. I don't remember why she got a thyroid ultrasound, but it led to an ultrasound report that had this that was rather short. It had a section on the technique, and a section, 2 paragraphs on an overview of the thyroid, and then 2 nodules described in this report in 2 lines. There was a nodule in the right lower lobe with a size characteristic of 7 by 4 millimeters, and then 1 statement about the nodule being hypoechoic. And that was the only way the nodule was characterized. And then another nodule within the lower lobe, but the side is not mentioned here. And it is 4 by 3 millimeters. And once again, the echogenicity is characterized, and that was all. And then in the impression, we have several typos about the 1 centimeter nodule, and then of the other 4 millimeter nodule. And then the recommendation here was really an option. It was do a 6-month follow-up, which is really short from our point of view, and then, or that the person could have an ultrasound guided aspiration of the dominant nodule. And I think these terms of dominant are particularly scary for the patient. So aside from the typographical errors, this report doesn't really have a full description of the features that all societies use to characterize nodules, and the recommendations are rather ambiguous and also incorrect. And so that leads me to this article that just came up this week. It was published online, and it is an article that was from Canada, and these authors took 1,930 thyroid ultrasound reports, and they answered this very question about the quality of our radiology reports. Do we describe all the features to make a decision to use ACR TI-RADs or any of the other risk stratification criteria? So they had 6 features that they were looking for. 5 of them are the descriptors used in ACR TI-RADs, and then the 6th feature was the nodule size. They found that of the reports that were reviewed, the mean score out of 6 was 2.57. And then they determined that the nodule needed to have 4 or more features in order to actually correctly classify it with one of the risk stratification criteria. And shockingly, and even maybe not surprisingly, less than 14% of reports had these features in order for someone, an endocrinologist or a surgeon, to classify the nodule under one of the risk stratification criteria. So this sort of sets the tone of how thyroid ultrasound is done in North America. So why would you not adopt ACR TI-RADs? I've heard many of these comments in participating in ACR TI-RADs activities and doing talks. It's more time consuming to report all 6 features, right? Instead of maybe 2, as in that previous report, just the echogenicity and the size. There are too many radiologists to teach this new system to, and it's time consuming. We're all busy in our day-to-day work anyway. Some comments I've received are that the referrers don't like it. They think the reports are too long. And the referrers prefer another system, such as the ATA system, or they just like the way we did it in the past. And then finally, the sonographers don't feel confident about using ACR TI-RADs. then why would you adopt ACR TI-RADs? And then this really gets to the crux of my next couple of slides. It gives you better patient care, and that's through improved quality of the report, and also the fact that ACR TI-RADs performs better compared to no criteria or other criteria. Specifically for improved quality of the report, it gives you a better descriptor of the findings of the nodule so that ACR TI-RADs or other risk stratification criteria could be applied. It makes the recommendations more standardized and it reduces variability. So let me talk about that in this paper. This was a paper that was published in JACR in May, so just this month. It is about improved quality of the thyroid ultrasound reports after implementing ACR TI-RADs. This was a study that was done with radiology partners. And in this study, we implemented this new structured reporting template, which had the nodule number and the size and the location, a descriptor of the nodule features. This is a pick list, so not all of this text appears. It's just solid if it's solid, echogenicity, hypoechoic if it's hypoechoic. So it's not usually this busy, but it lists all of the 5 features under ACR TI-RADs. And then it gives recommendation for the total points and the TI-RADs classification. It talks about a change in the nodule if there was a previous ultrasound, and then finally it gives a recommendation. Now, in this study with radiology partners, the first phase was just looking at the text reports without implementing this structured reporting template. The second phase was using the first half of this template, so just the location and the size and the descriptor. And then in the third phase, after ACR TI-RADs was published, we introduced the next part of the structured reporting template. So we evaluated amongst these radiologists what happened if we used a structured reporting template with the features and what happened if we implemented ACR TI-RADs. And in each of these 3 phases, phase 1, 2, and 3, we looked at the recommendations in the radiology report. And there were 4 options that we saw, that they would recommend a biopsy, that the radiologist would recommend an ultrasound, a follow-up ultrasound, that there would be a recommendation that the nodule needed no follow-up or biopsy, or that there was nothing said about the nodule, no management recommendation. When I first started doing this study, I really thought that we would see fewer nodules being biopsied with ACR TI-RADs, but that's not what we saw. There was actually no statistically significant difference in the nodules recommended for biopsy with ACR TI-RADs, with the template, or with the final recommendations. So that was surprising in the early phases. But what we did see is that after implementing ACR TI-RADs, the improvement really was that there were far fewer nodules with no recommendations. You can see without ACR TI-RADs and a RAD system, 1/3 of nodules had no recommendation of what to do. And what does this lead to? Well, it leads to the referrer and the patient being confused and maybe more likely to have biopsy or follow-up when it wasn't necessary. Now, in the next part of the analysis, we looked at the frequency of specific findings, the 5 findings under ACR TI-RADs. And we saw that in phase 1, when there was just free text, that the reporting, particularly of shape, margin, and echogenicity, were very infrequent. When we implemented the structured reporting template, there were actually fields that they had to fill out. So in phase 3, all of these features were reported, whether they were present or absent. And now when we looked at the frequency of the suspicious features, this was revealing of why there were the same amount of biopsies. In phase 1, when it was just free text, the frequency of taller than wide, suspicious margin, and punctate echogenic foci were relatively low. But we saw that in phase 2 and 3, when the radiologist had to create a checklist and look at these features in the nodule, the frequency of these findings, these suspicious findings, were actually much higher. So it shows us that in phase 1, just because the radiologist didn't mention these features wasn't because they weren't present. It probably was because they weren't specifically looking and didn't see them. And as a result, the average ACR TI-RADS points was higher in phase 2 and 3 compared to phase 1. And that is why in phase 3, the same number of biopsies were recommended. It's because radiologists saw more nodules with these suspicious features that would appropriately be recommended for biopsy. So the take-home point from this study is that a structured reporting template serves as a checklist, and that ACR TI-RADS results in more definitive recommendations. A next study that talks about reducing variability is a study that we did that looked at inter-observer variability. And Franklin is going to talk about this article in more detail. So I'm going to skim over this, but what I want to point out is that we looked at various sonographic features, and we saw that margin and punctate echogenic foci had the poorest agreement. It was a fair. And that an overall recommendation, if radiologists weren't given ACR TI-RADS, was fair, verging on slight. But with ACR TI-RADS, no matter how radiologists varied in their interpretation, it actually improved the recommendations being more consistent. It was now having a kappa of 0.51, which put it into the moderate agreement range. So in this study, we had high variability in interpreting several ACR TI-RADS findings, but applying ACR TI-RADS reduces the variability. And then the final paper that I'll talk about is one that was published in Radiology in April of this year. This study took 8 radiologists who interpreted 100 nodules, the same nodules, and these radiologists were asked to provide recommendations for biopsy as well as interpret the features of the nodules. In addition, we had 3 experts that interpreted the same 100 nodules as the gold standard in interpretation. And this study really talks about the reduction in thyroid nodule biopsies and improved accuracy. When radiologists were asked to categorize the nodules from benign to highly suspicious before knowing about ACR TI-RADS, this is in the pink color, most radiologists thought nodules were mildly suspicious. Now, I think this is a really good sign of radiologists being unsure and hedging, being in the middle ground. After we used their nodule interpretation and applied ACR TI-RADS, we can see that many more nodules were moderately or highly suspicious. And this makes a lot of sense because these group of nodules were nodules that were all biopsied. So they were more suspicious than the everyday diagnostic ultrasound thyroid nodule. Now, despite more radiologists saying that nodules were mildly suspicious, we found that compared to radiologists' own judgment, ACR TI-RADS applied to their own interpretation would have reduced the number of thyroid nodule biopsies from 80 to 57. Now, with fewer biopsies, how did this affect the sensitivity and specificity? This was the sensitivity and specificity and accuracy on average for the 8 radiologists. And this was the sensitivity, specificity, and accuracy after applying ACR TI-RADS to their interpretations. You can see sensitivity doesn't change significantly, but specificity certainly does. It improves from 20 to 44%, and accuracy markedly improves as well. We then use the expert interpretation and compared it to other risk stratification criteria, and we found that ACR TI-RADS has the same sensitivity as other categorization guidelines out there, but the specificity was definitely better and the accuracy was better. And Bill has a larger study that looks into this, so I'm going to move on. I do want to emphasize that what does it mean to miss a malignancy? It doesn't mean that the malignancy was missed because of an incorrect interpretation, but there are certainly even high suspicion nodules that don't meet the category for biopsy because they're too small. And we definitely covered this in the past webinars that we're aiming to biopsy nodules that are suspicious, but also result in a significant outcome in that if they're untreated, they'll lead to harm for the patient. And as we know, thyroid cancer is very indolent and there are many cancers that don't progress and can be safely observed. But this table shows the 5 thyroid malignancies that had a recommendation not to biopsy by one or more observer. And we see here that there are 2 radiologists in particular that did not recommend follow-up for malignancies, and therefore these malignancies wouldn't be observed in their annual follow-up. And this represents just two malignancies here, and only 3 out of 120 malignancy encounters, and so 2.5% of malignancies. And here the problem was misinterpreting a solid nodule with some cystic components as spongiform or mixed cystic solid. So in this study, we identified definitely composition as an area to focus on. So the take-home point from this article is ACR TI-RADS reduces a number of thyroid nodules biopsies when compared to radiologists' existing practice patterns and other criteria, and that applying ACR TI-RADS improves the specificity and accuracy due to reduced number of benign biopsies. So to conclude my section, using ACR TI-RADS does provide better patient care. It improves the quality of the report, even if we're not looking at outcomes of whether the nodule was malignant or benign. It gives us a better descriptor of the findings if we use a structured reporting template. It makes the recommendations more standardized, that is, radiologists are more consistent with each other in their recommendations, even if they report the nodule differently. And then it reduces the variability in the recommendations. And then the other advantage is that ACR TI-RADS does have a better performance compared to no criteria or compared to other criteria. And Bill will be reviewing his studies as well as some of the studies performed in Europe since ACR TI-RADS was published. And so I'm going to hand it over to Franklin now to do his section.
Thank you, Jenny. And as soon as I have control, I'll go on to the next slide. To start off with, since publishing ACR TI-RADS, we've heard from radiologists and other practitioners in multiple places saying some of what Dr. Hong alluded to, which is that they're struggling with some ACR TI-RADS features because they're reporting them and looking at them for the first time. So my first question is, which ones are the most challenging for sonographers and physicians to deal with? And as I alluded to during the last webinar, there are a number of features that seem to give people more problems. I specifically talked about mixed solid and cystic nodules being problematic, and I talked about comparing a mixed nodule that has a roughly even distribution like the one on the left versus one with eccentric solid material like the one on the right. And this is based on my anecdotal experience. But I'd also like to talk about this in the context of variability that Dr. Hong also presented a little bit earlier. And that is the importance of inter-observer variability. Stated another way, ultrasound features aren't helpful if observers don't agree on whether they're there or not. For example, if one observer says that a nodule is very hypoechoic, and another says that a nodule is hyperechoic, they'll receive different scores and be subjected to different management recommendations. Inter-observer variability was assessed in this paper that Dr. Hung was lead author on, and this is the paper that she showed with 8 board-certified radiologists looking at 100 proven nodules, assessing their agreement on feature assignment and biopsy recommendations based on their practice. And this is a section from the same table that Dr. Hong just showed, and highlighting that some features, notably margin and punctate echogenic foci, had low kappa values indicating high inter-observer variability. Not surprisingly, macrocalcification, which is usually pretty easy to determine that it is present or not had a pretty good kappa value, and the others were in between. So what do you do with this? We look at this table and say there are some features that people can't agree on. Where do we go? There are basically two routes that we can take. The first would be to eliminate or change the definition of some features. Unfortunately, these features have all been shown to have utility in distinguishing benign from malignant nodules. Therefore, doing this would not be productive. The alternative, and this was the conclusion in this paper, is to apply more education. And this is something that we're doing by means of these webinars, by means of publications, and it's something I'm going to touch on in the end when I talk about the future of ACR TI-RADs. But the key point is that decreasing inter-observer variability requires people to look at nodules, look at features, and one thing that, and try to increase their confidence that a feature is there or not. And one thing that really helps in practices is have several observers review cases and look at nodules and see if they agree on whether features are present or absent to try to improve their inter-observer agreement. The next question, which I'll spend a little more time on, is what are the major differences between ACR TI-RADs compared to the American Thyroid Association and the SRU recommendations? And I chose those two because the ATA recommendations are frequently requested, particularly by our endocrinologist referrers. And the SRU recommendations I chose because many practices are still using them, particularly in radiology practices. At the highest level, really, there are a few differences. All the risk stratification systems start with imaging, then progress to characterization of nodules, and finally come up with management decisions. So this is at a very high level, so-called 50,000-foot view. But there really are differences when you zoom in. Let's start off with imaging. Well, you'd think that imaging is imaging, right? But the truth is that there are some distinctions between the systems that are highlighted in this table. Starting off with the number of nodules to scan a report, ACR TI-RAD specifies up to 4. And by this, I mean that this is the maximum number of nodules that are formally reported and for which all the features are enumerated and they are classified. It doesn't mean that you don't see the other nodules. It just means you pick up to 4 to formally document in your report. Neither the SRU nor the ATA guidelines state a limit. And we chose this because we thought it was something that could be applied practically in a typical ultrasound practice. There are slight differences in measurements. Both the ACR TI-RAD system and the ATA specify that nodules should be measured in 3 dimensions. Interestingly, the SRU doesn't really talk about 3-dimensional measurements, although it refers to the maximum 2 measurements, and that indicates the maximum measurement of a particular nodule. There are more differences in the characterization step. ACR TI-RADs began with a feature lexicon that was published in 2015. I'll show more about that in a moment. And we did that because we wanted to have a basis on which ACR TI-RAD's classification would be founded. Neither the SRU guidelines nor the ATA guidelines specifically referred to a lexicon of ultrasound features. In fact, in both of them, it was sort of assumed that a particular feature that was listed as a criterion, you would know when it was present or not. And we felt that having a lexicon with examples was an important foundation for what we were doing. Of course, there are differences in how risk assignments occur in the 3 systems. ACR TI-RADs points assigned in 5 feature categories compared to a tabular method for the SRU based on composition and size. And by composition, I refer to all the internal characteristics of a nodule. And for the ATA, patterns of appearances and composition and size. And finally, lymph nodes, which are not formally considered in ACR TI-RADs and were considered by the SRU and ATA. And this is the front page from the lexicon paper from 2015. And here's the table of the 5 feature categories that you see here on the left. And I've outlined the more suspicious categories in red that I'm highlighting here. And these were translated into the well-known by now ACR TI-RADs table, or chart, which I won't go through in detail, the 5 categories in which you choose one in each of the first 4, and then all that apply in the last one, add up the points and combine that with the size to come up with a TR level ranging from 1 to 5, and decide based on that whether to recommend an FNA or follow-up. Compare that to the SRU table on the left and the ATA on the right. On the left, we see that this SRU table showed these different appearances, and each of those was associated with a management recommendation. In essence, these are really patterns. The ATA is definitely pattern-based. You basically take the nodule that you're looking at and try to match it as closely as you can with one of these patterns in the chart. And as you go up in the chart from bottom to top, the suspicion level and the recommendations for biopsy change. The problem with patterns that we've highlighted in previous webinars is that not every nodule fits a pattern. In fact, in one recent study of 2,000 nodules, 100 or 5% were not classifiable by the ATA guidelines, and those nodules had a 19% malignancy rate. There are even greater differences in management between the systems. The size thresholds, particularly, ACR TI-RAD specifies thresholds of 2.5, 1.5, and 1 centimeter at TR3, 4, and 5. The SRU talks about either strongly considering or just considering biopsies depending on features and size. And the ATA says FNA or consider FNA depending on the pattern and size. Follow-up in ACR TI-RADs, as I mentioned earlier, is specified as each TR level. So if you have a nodule for which FNA isn't needed, you know whether to recommend follow-up or in some cases no follow-up. And the SRU had no specific recommendations for follow-up intervals, and the ATA's recommendations are limited. As I mentioned earlier, lymph nodes are not formally considered in ACR TI-RADs, although we said that lymph nodes should be biopsied if abnormal. The SRU said ipsilateral nodules should be biopsied if there's an abnormal lymph node on that side, and the ATA said to biopsy an irregular nodule if there's a suspicious node. The differences are highlighted in this chart from a recent paper in radiology that compared these 7 systems, and I've highlighted the sensitivity, specificity, and accuracy for ACR TI-RADs, and you can see how that compares to the others. We knew in designing ACR TI-RADs that our sensitivity would be lower than other systems, but you can see that our specificity and our accuracy were considerably higher, and Bill will talk about this shortly. Why does ACR TI-RAD specify larger size thresholds for FNA of some nodules? Going back to the pattern system in the ATA guidelines, you can see all the patterns and the different size thresholds as you go up in suspicion. If you overlay on that the point levels, you can see that, for example, at the high suspicion levels, most of the nodules would be classified as ACR TI-RADs 5, and would be biopsied in ACR TI-RADs at a threshold of 1 centimeter, concordant with ATA. This pattern, hypoechoic with irregular margins, would be classified as TR4 and biopsied at a 1.5 centimeter threshold. Similarly, for intermediate suspicion nodules, which would both be classified as TR4, the ACR guidelines would biopsy at 1.5 centimeters versus 1 centimeter for ATA. At low suspicion, TR3, these two TR3 nodules would be biopsied at a threshold of 2.5 centimeters in the ACR TI-RADs compared to 1.5 centimeters for the ATA. What underlies our decision to use larger size thresholds? And the questions we looked at what sizes do nodules become problematic? And are ultrasound measurements, in quotes, accurate? Because accurate is a relative term. Many of the other guidelines, including the ATA, based their recommendations for size on this study from 2005, which looked at gross tumor size versus risk of distant metastases. And they said in this paper that there was an abrupt takeoff at 2 centimeters. However, they were using gross tumor size, and I'll talk more about that in a moment. Since then, Dr. Nguyen and several of us published a paper in Thyroid earlier this year, and we found no threshold effect on risk of distant mets or nodal mets or local invasion for tumors less than 4 centimeters. And moreover, didn't find a great change in mortality until the size was greater than 2.5 centimeters. As well, previous research showed that ultrasound measures nodules by an average of about 5 millimeters. And we took all these things into consideration in our larger size thresholds. As well, the fact that we supply follow-up recommendations mitigates the likelihood of us missing a cancer over the long term. Finally, can you use ACR TI-RADs in the ATA guidelines simultaneously? Well, yes, you can, but you need to be prepared to deal with discrepancies. And those are highlighted again in the ATA chart showing the nodules for which there would be significant discrepancies between the ATA and the ACR TI-RADS guidelines. If you report both, you have to be prepared to deal with referring physicians who are going to notice the discrepancies. And since patients get to see reports more often than they used to, in fact, it's becoming the norm, they would often have questions. So with that, I'll turn the control over to Dr. Middleton for his presentation. Thank you.
Okay, this is Dr. Middleton speaking from Mission Control. So my assignment was to compare the results of the ACR TI-RADs to other existing stratification systems. And I really want to focus on 3 specific studies, a little bit on a 4th if we have time. This is the one that I will start with, and it comes from the Society of Radiologists and Ultrasound, who developed a group of investigators that looked at nodules between 2006 and 2010. It was a group of 6 different academic medical centers. And I'm focusing on this article first because it's the largest of the existing comparisons, and also because the first author is a very close and personal friend of mine. So the cohort was 3,400, about 3,400 nodules that had definitive FNA and or histology results. We looked at all these nodules and retrospectively determined their ultrasound features, features that you all are familiar with now. And then we classified each nodule based on the ACR TI-RADs from 2017, the Korean TI-RADs from 2016, and the ATA guidelines from 2016. So of the 3,400 plus nodules, a little over 3,000 were benign and 352 were malignant. And you can see the breakdown of the different types of malignancies that were included. Majority were papillary or the follicular variant of papillary cancer. And then for each one of these nodules, we divided them up into categories depending on what each classification scheme would place them. So they would either place them in a FNA recommendation, a follow-up ultrasound recommendation, or no further evaluation recommendation. And this is a chart that shows the breakdown of where the nodules were classified on the different systems. So up here at the top are the relatively innocuous looking nodules, very low suspicion, benign lesions, and the TR1s and 2s for the ACR TI-RADs. And then as we move down, we get into the more suspicious nodules. And you can see that there's a large number of nodules in each one of these categories. But what I really want to focus on is the non-classified nodules. So notice that in the ACR system, there were no nodules that could not be classified. On the other hand, in the ATA and the Korean classifications, there were at least a substantial minority of nodules that could not be classified, particularly in the ATA guidelines. And when we just focus on those guidelines, we found, as Franklin mentioned earlier, that there were 14% of the ATA nodules that could not be classified into any of these risk categories. And of those, 9% were malignant. And that's a fairly significant minority of the non-classified nodules. And then if you just look at all malignant nodules, 13% of them were not classified based on the ATA guidelines. And here's a chart that I do want to spend a little bit of time with. So it looks at the ACR, the ATA, and the Korean guidelines, and it looks at these different parameters. So ACR has definitive recommendations for which nodules should be biopsied and which nodules should be followed, and then leaving the rest of the nodules as nodules that don't require any further evaluation. The ATA has spotty recommendations about which nodules should be followed. Korean guidelines don't have any recommendations about follow-up. So I'm just going to focus to begin with on the biopsied categories. We'll talk about followed categories later. So in this first row, yield of malignancy, that refers to the number of biopsied nodules that turn out to be malignant. And you want that to be high. You want to have as many nodules at your biopsy be malignant and as few nodules as possible be benign. You want your yield to be high. And as you can see in this study, the ACR yield was higher, substantially higher than either the ATA or the Korean yield. In the next row is another statistic, and this is the percentage of malignant nodules that would be biopsied using the different systems. So this is a number that you want to be high. You want to biopsy as many of the malignant nodules as possible. In the ACR system, it was 68% and a little bit higher, significantly higher in the ATA and the Korean systems. And this is something Franklin mentioned earlier, and this is something we expected all along when we set up the guidelines. If you just look at the nodules that are greater than a centimeter, greater than or equal to a centimeter, then that sensitivity or that percentage of malignant nodules that are biopsied increases quite a bit to 83%. It also increases with the other systems, and there remains a significant difference between the three. Then we move on to this next row where we focus on benign nodules. So the percentage of benign nodules that are biopsied in the ACR system is 47%. You want this number to be as low as possible. You'd like to biopsy as few benign nodules as you can. And in our study, this was significantly lower than either the ATA or the Korean systems. And again, if you just look at nodules that are bigger than or equal to a centimeter, assuming that anything less than a centimeter is not significant regardless of what it is, you see these statistics that the ACR biopsies 50% of the benign nodules that are greater than or equal to a centimeter. ATA and the Korean systems biopsy a little more than 80%. Okay, so next let's focus on these followed nodules. So since the ACR does give discrete recommendations on what should be followed, I wanted to look at this as well. And of the nodules that would receive this recommendation, about 12% turned out to be malignant. Of all the malignant nodules, about 21% would be followed under the ACR criteria. So if you look at this, if you add these two numbers up, that's almost 90% of the malignant nodules would either be biopsied or followed under the ACR system, which is higher than the number that would be biopsied under ATA or Korean. If we just look at the malignant nodules greater than a centimeter, 11% would be followed. If we look at benign nodules, 18% would be followed. And again, if you add these two numbers up, the total continues to be less than the nodules that would be biopsied with the ATA system or the Korean system, much less the nodules that would be followed with those systems. Now let's talk a little bit about the ATA follow-up. So ATA does have some guidelines for follow-up. If you look at all the nodules that did not meet guidelines for biopsy, and that's a small percentage in this study, only 22% of nodules didn't meet guidelines for biopsy by the ATA recommendations. But of these 756, 55% had no recommendation either for or against follow-up. 16 of those were malignant. 11% had a recommendation for follow-up in 6 to 12 months, and 41, or half of those, were malignant. 27% of these nodules that didn't meet guidelines for biopsy had a recommendation to consider follow-up in 12 to 24 months. I'm not sure what referring clinicians do with a recommendation to consider follow-up, but of those, 26 were malignant. And there were only 50 nodules out of all of those where there was a recommendation for no further follow-up. Now, those 50 nodules account for just 1.5% of all of the nodules that were evaluated. So only 1.5% had a definitive recommendation for no further evaluation, i.e. no biopsy or no follow-up based on the ATA guidelines. Now, you compare that to the ACR guidelines, 32% had a definitive recommendation for no further evaluation. So compare those two results. ACR leaves you with final recommendations of no further resources need to be wasted on 32% of nodules. In the ATA, it's just 1.5% of the nodules. So the conclusion from this study was that the ACR TI-RADS compares favorably with the other systems. The ACR system has a higher biopsy yield of malignancy, primarily because of reduced number of biopsies of benign nodules. It also eliminates further evaluation, i.e. biopsy or follow-up, of a much higher number of nodules. The ATA and the Korean systems result in biopsy of a higher percentage of malignant nodules, but this difference is at least partially mitigated by the follow-up recommendations included in the ACR system. So the next paper is one that Franklin has referred to a couple of times. This comes from a group of Korean radiologists who looked at 2,000 nodules, and they compared the diagnostic performance of 7 different society guidelines. Of their 2,000 nodules, about 1,500 were benign, and the benignity was proven by surgery or histology in a small percentage, by a benign biopsy with a repeat biopsy that was also benign in a smaller percentage. And most of them had benign biopsies to begin with and then were followed for 12 months. So very good proof that these were benign. There were 454 malignant nodules, and almost all of those were ultimately proven surgically. And you can see the breakdown of the types of malignancies. Again, papillary and follicular variant of papillary cancer were the most common. And these are the standard statistics for the different societies. So this is the ACR, the American Thyroid Association, American Association of Clinical Endocrinologists, the National Cancer Comprehensive Network, French Society of Endocrinology, Society of Radiologists and Ultrasound, and the Korean Thyroid Association. And if you just look at sensitivity, you want that obviously to be high. And as we've said before, that's one of the things that is lower with ACR TI-RADS, lower than most of the other systems. Specificity, on the other hand, is one of the strengths of the ACR. And as you can see, it had the highest specificity of all of the guidelines. Positive predictive value, obviously you want that to be high. And in fact, it was the highest in the ACR guidelines. And negative predictive value, you want that to be high as well. And that was fairly similar in all of these categories. There was a little difference in the negative predictive value. And overall accuracy, again, was highest in the ACR system compared to all the other systems. So it performed very well when compared to many other established guidelines. And then these authors also evaluated the systems in a manner somewhat similar to the first study that I talked about. They looked at the total number of nodules that would require biopsy based on the different systems, and you can see the ACR recommended biopsy in the fewest number of nodules of all of these. The yield of malignancy and the yield of benignity, also very similar to the previous study. You want the yield of malignancy to be high, and it was the highest in the ACR. The yield of benignity to be low, and it was the lowest of all the possibilities. And then they also looked at something called unnecessary FNA rate, and that was defined as the number of benign biopsies divided by all of the nodules in the study. And again, that's something that you would want to be as low as possible, and in fact, it was as lower than any of the other guidelines. And then they also looked at false positive rate, and I show this just because the false positives were lowest in the ACR guidelines, but they don't really define how they the formula they used to calculate that. So I take that with a little bit of a grain of salt. And then the final big study that's come out since the TI-RADS was published is from a group of primarily endocrinologists from Italy. And they looked at the performance of the ATA, the AACA, and the ACR systems in identifying cytologically high-risk thyroid nodules. And they looked at a little more than 1,000 nodules. Fine needle aspiration was used as the gold standard. There was no surgical or histologic correlation in this study. They had over 900 nodules that were benign, and they had 113 nodules that were presumably malignant based on high-risk cytology. So some of these categories that were in the benign category and in the high-risk category fell into cytologies that were indeterminate. They divided the indeterminate cytologic results into low-risk indeterminates and high-risk indeterminates. So they assumed that all of these would be malignant and all of these would be benign, but clearly that's not the truth. The majority in each case would be true, but not all of them. So the manuscript reviewer in me would have raised a lot of red flags about this way of defining nodules. Nevertheless, they did provide some useful data. And this, again, sort of highlights the fact that there are non-classifiable nodules in both the ATA guidelines and the AACE guidelines, 5% in ATA and 2.8% in the AACE. And of the ones that were non-classifiable in the ATA, 9 were cytologically high risk. ACR, again, was able to classify all the nodules. And the primary reason that I wanted to review this article is they also showed receiver operating curves for the 3 different systems. And for those of you that are familiar with this, I won't spend too much time with it, but this is a plot of sensitivity on the vertical axis and 1 minus specificity on the horizontal axis. And for receiver operating curves, you want the curve to be as far above this dotted line as possible. You want it to be in this upper left-hand corner as much as possible. And you can quantify that by calculating the area underneath the curve. And as you can see here, they've done that. The little triangular line, or the line with the triangles, is the ACR system. The line with the black boxes is the AACE, and the line with the gray circles is the ATA. And you can see that the area under the curve is the best for the ACR TI-RADS. So in conclusion, they wrote this, that their study shows that the ultrasound classification system proposed by the ATA, the AACE, and the ACR differ in their ability to identify nodules at high risk of malignancy. In particular, the ACR TI-RAD classification system has the highest ROC area under the curve for the identification of high-risk nodules and is the only ultrasound scheme able to classify all thyroid nodules. Their results also confirm a relevant limitation of the AC or ATA classification, which leaves unclassified nodules at relatively high risk of malignancy. So based on the current evidence, there are some conclusions that you can make. First of all, the ACR classifies all nodules. It's the only system in most of the existing systems that will classify all nodules. The ACR TI-RAD reduces the total number of nodules requiring FNA or follow-up compared to other systems. And the ACR TI-RAD reduces the number of benign nodules requiring FNA or follow-up. ACR TI-RADs will miss more cancers than most other systems, but many of those missed cancers are less than a centimeter in size, and many of those that are missed will be followed for 5 years based on the follow-up recommendations in the ACR TI-RADs. So that's really all the time that I have. We do have a few more points to make, and I'm going to turn the controls back over to Franklin.
Thank you, Bill. And in the last few minutes, I want to talk about where we're going next. So you've heard a fair bit this morning about ACR TI-RADs versus other systems. But we have to remember that this isn't a contest. We all have the same goal, which is to reduce the number of biopsies of benign nodules while detecting appropriately malignant nodules. There are more similarities between all the systems out there than there are differences. So to paraphrase Rodney King, can we all get along? I think the answer is yes. And to that end, I started a grassroots effort. We're calling ourselves the International Thyroid Nodule Working Group. Our first teleconference was held 1 week ago, and although it makes it look like we spent 2 days on this, it was really 70 minutes. The 2 dates are because of the different time zones involved. And this involved 17 radiologists, endocrinologists, and surgeons from all the countries that you see here. And this was an organizing call to decide where to go next. But we agreed that our ultimate aim is essentially a universal TI-RADs. We're going to do other things as well. For example, we're going to look at creating an internationally available atlas of ultrasound features to answer the educational question or issue that I mentioned earlier. And I don't know, as I speak to you this morning, where this will go, this afternoon rather, where this will go. But I'm hopeful that this will be a good cooperative effort. It's not going to be done quickly within a few months. It's going to take time. But both Drs. Hong and Middleton were on the call, and I think they would share my enthusiasm for what was expressed by thyroid experts from around the world who said that we should work together and try to reach consensus. So with that, I'll pass control back on to Dr. Hong to conclude.
Yes, and the other initiative we have is a multi-center thyroid ultrasound registry that's grant funded from the ACR and Akron with 6 practices, both private and academic, being involved. This research registry will eventually be a practice registry so that your sites can participate as well and get some benchmarking nationally of how you're performing with regards to biopsy rate, malignancy rate, and then the frequency that you're interpreting these findings. So that is the other aspect of looking forward with ACR TI-RADs, gathering more evidence to compare it to other risk stratification criteria out there. Well, we're on to our last 2 minutes. I wanted to show you the website for ACR TI-RADs, which will have links to publications as well as links to all of the webinars that we've had. This is the Thyroid Ultrasound Registry and the participating sites, and I'd like to thank them for their participation. The recording will be available. All of the webinars, how we do it, frequently asked questions, and evidence behind ACR TI-RADs will be made available. I would like to take this moment to thank Lauren Hicks from the ACR for coordinating and managing these efforts. Again, with this webinar, she'll have the questions and the timestamps of when they appear on the webinar. Franklin and Bill did a fantastic job in simplifying the literature and making it digestible. I'm certainly grateful that we left enough time for Bill to most eloquently describe and compare the risk stratification guidelines. Franklin, that chart on TI-RAD superimposed on the ATA chart was wonderful. I think all practices should have that up in their reading room if their referrers like ATA guidelines. So that is it. Thank you to everyone. Bill, Franklin, do you have any additional comments?
No, I just would like to add my thanks to Lauren for her invaluable assistance in getting these organized. And it's been fun, it's been interesting and educational, and I hope valuable to people who've watched these webinars.
Thank you, everybody.
I second all of those motions.
Right. Thank you. Thanks for spending an hour with us.
Bye-bye.
Bye-bye.
Bye.
I'm Richard Kloos. I'm the Secretary and Chief Operating Officer of the American Thyroid Association. Hopefully I said hello to many of you yesterday. And I again want to take this chance to welcome you here to the American Thyroid Association meeting. And I want to specifically point out my thanks to this our program committee and our course leaders for today for putting this together for you. My sense is a strong desire to tell you how important you are to our future. The American Thyroid Association knows that our future is in our youth, our trainees, and it's a strong priority for us to make you feel welcome, to make a high-quality educational opportunity. You've got two outstanding teachers here today, and we hope that this is if not your first, one of your early good memories of coming to our meeting. We hope it's one that you'll come to year after year, tell your colleagues, and see our society grow and benefit you. So if you can help us come up with ways to make this more meaningful to you, please share those. Please check out our website. We spent a lot of time developing what we think are tools that would be meaningful. So without further ado, I'll hand this over to Andrew and Stephanie, and I thank you.
So as Stephanie outlined, in a little bit, in a few words, the whole program for the few days that we're here. For this morning specifically, I'm going to go over the basics of thyroid ultrasonography. Stephanie is going to follow up with a more advanced set of slides on thyroid ultrasound and FNA, including lymph nodes and parathyroid glands. And then we're going to have a little bit a lecture by one of our cytologists, and we're going to have the practicum. So just for a show of hands, how many of you have ultrasounds that the fellows use in your program? Okay, pretty much everybody. How many don't? Maybe that's the easier. Okay. And then of those of you that have ultrasounds, mostly peds. And of those of you that have ultrasounds and the fellows use them, I assume the majority also do the FNA-guided ultrasounds of nodules. How many of you are in your program do you biopsy lymph nodes, ultrasound-guided biopsy of lymph nodes? So fewer. Okay, so thanks for that show of hands, and I'll get started. So, as most of you know, a thyroid ultrasound uses high-frequency sound waves to take a picture of the thyroid gland. As seen in this pictorial, the sound waves that are used are anywhere from 7 to 15 megahertz. The higher the megahertz, the less penetration, but the better the images. The lower the megahertz, the more penetration you get, but the more grainier the images are. So when you're doing thyroid ultrasounds, and depending on whether the lesion is superficial or deep, you should be adjusting the megahertz on your ultrasound, and in some cases, it's usually tiered to around 8, around 10 to 12, and around 14 to 15, or you may get a designation that's Gen for general, which is around 10 to 12, Pen for penetration, which is 7 to 8, and high resolution, which is 14 to 15. So, as you all know, the patient lies in the supine position. Hyperextension and positioning of the neck is very important. Ultrasound gel is applied to help with the transmission of these sound waves. The resolution we discussed, and of course the neck is visualized in both the transverse and the longitudinal planes. In terms of anatomy, the lobes are oval-shaped with a rounded superior pole and elongated inferior pole. The lobe dimensions are as you see there. It's variable, but on the order of 4 to 6 in length and approximately 2 centimeters in thickness. And you'll hear thyroidologists or your supervisors, mentors in your clinics refer to 10 to 15, 10 to 20 cc's as the volume of a normal thyroid gland. In terms of looking at this a little bit more anatomically and trying to mirror an anatomic cartoon with what we see on ultrasound, we of course see the trachea, which is centered here. The esophagus is usually positioned as shown here rather than right behind the trachea as shown in the cartoon. The thyroid overlies the trachea with your isthmus in the middle, carotid and jugular as shown here to the left and right, and surrounded by sternocleidomastoid muscles and other neck strap muscles, which can usually be easily differentiated from the thyroid, although if you have a hypoechoic thyroid gland, it can be difficult, and it can be difficult as you'll see in the advanced section of this presentation. It can be difficult to distinguish muscles from lymph nodes in the neck once the thyroid has been removed, and we're doing follow-up ultrasonography for patients with locally metastatic thyroid cancer. In the longitudinal plane, you see the thyroid as pictured here with the lower and upper poles, and as you move more medially, you'll see tracheal cartilage. As you move laterally, scanning the neck, you'll see your carotid and your IJ as shown in the pictograph on the right. So essentially, and we'll go over this when we're doing the practicum, you're scanning the neck in a transverse way, much like a CT scanner, hopefully trying most of the time to remain perpendicular so you can easily you can visualize the anatomy and know what you're seeing, and then in a similar way doing your transverse sections going from midline all the way out to the blood vessels, back to the trachea, and same thing on the other side. So now what about the use of thyroid ultrasound in the diagnosis of thyroid nodules? Thyroid nodules are common, and they increase with age just by palpation, but since we've begun using ultrasound from the early to mid-90s, and now in this after the year 2000, we've been discovering many, many more nodules that were previously clinically not detected. And the majority of these lesions, the prevalence of thyroid nodules, tends to occur more commonly in women, and they increase as we age. So if you look at every age group, here we have women and men 20 to 30. There's a twofold increase in prevalence of thyroid nodules in women compared to men, and that holds true as we age, with 40 to 50-year-old women having almost a threefold increase compared to the younger women, and we continue to have this increase in prevalence in females compared to males. So what are we missing? Well, Part of this, what we're missing, is in multinodular glands. So one may palpate this large left-sided thyroid nodule, but miss this smaller right-sided, deeper thyroid nodule. Similarly, given the depth and the size of the sternocleidomastoid and strap muscles here and the depth of this nodule, one may miss this relatively large 1.5 solitary nodule because of the depth and the overlying strap muscles. And there's also issues that have to do with consistency of the surrounding tissues and thyroid, normal thyroid, compared to the density or firmness of the nodule. The more similar, the less likely you'll palpate the nodule as being different from the surrounding tissues and normal thyroid. The more different they are in consistency, the more likely you are to palpate something that's even deep. So depth and consistency of the nodule are important. And sometimes we feel nodules that may not be there. So this is an example of a hash gland with what we call pseudonodules, where you could see that you may be palpating what you feel is a nodule here, but really it's an irregularity and heterogeneity within a hash gland. So looking at what we're missing a little bit more systematically, it's not surprising that we would miss the vast majority of less than 1 centimeter thyroid nodules. It's a little surprising that we would be missing 50% or close to 50% of these relatively larger and palpable to the most of us thyroid nodules that are 1 to 3 centimeters or larger. However, many of these are missed in the context of a multinodular goiter, where one nodule is palpated, but we miss the 2 or 3 other smaller ones that are less easily palpable. Nonetheless, and for these reasons actually, both the ATA and the combined recommendations of ACE and the South American and European thyroid associations with their guidelines listed here, the ATA 2009, ACE, ETA, and AME from 2010, both highly recommend the use of thyroid ultrasonography in essentially all patients who are suspected of having thyroid nodules. Now, what are the characteristics of thyroid nodules that we use or pay attention to? So there's echogenicity, hypoechogenic, isoechogenic, hyperechogenic, and we'll discuss a little further so a iso or hypoechogenic are more likely to be benign. Hypoechoic, the hypoechogenicity tends to carry a greater risk of malignancy, although, as we'll see, benign nodules can be hypoechoic. Benign nodules can have calcifications, and we'll discuss on the next slide the different types of calcifications that one can see and their significance. The presence or absence of a halo and how the margins look, irregular and lobulated versus smooth. And vascularity, and how that vascularity is distributed, peripheral versus central, when we talk about thyroid nodules, but also about when we discuss lymph nodes, which Stephanie will discuss in the follow-up talk. So calcifications, what kind of calcifications do we have? Eggshell calcification, which is what it says, a calcification that's peripheral and surrounds the whole nodule. It's unclear. The significance of eggshell calcification is unclear. There's insufficient evidence to claim it to be a benign versus suspicious finding. It's been seen in both cases, so I've outlined, it's outlined with a white border. As you'll see, the rest of the calcifications are outlined either in white, if they can be commonly found in benign and malignant lesions, in green, if they're more likely to be benign, and red, if they're always thought to be worrisome. So insufficient data for the eggshell calcification, but that's the first type of calcification. Then we have coarse calcification. So large hyperechoic foci within a nodule, as seen here, characterized by post lesion acoustic shadowing. This can be found in benign follicular adenomas, as well as papillary carcinomas, as well as sometimes they're thought to be characteristic of medullary cancer. So bordered in white, coarse calcification can be found in hash glands. So it can be found in both a benign as well as a malignant setting. Then we have punctate calcifications. And there are two types of punctate calcifications. You can have punctate calcifications with a comet tail artifact versus punctate calcifications without this comet tail artifact. When you have these punctate calcifications with a comet tail artifact, it's thought to be a benign finding. It's thought to be due to it's usually seen in more cystic or complex cystic lesions and thought to be due to thyroglobulin concentrations that are within the nodule. The comet tail artifact may be visible at the higher frequency of scanning, but sometimes you need to drop to a lower frequency of scanning to see the comet tail artifact. And these are highlighted in green because they're a universally benign finding, as opposed to your punctate calcifications without the comet tail artifact, which are worrisome, are more frequently associated with malignancy and nodules that contain these punctate calcifications without a comet tail artifact should be biopsied. So, having said that, let's first look at some benign appearing nodules. So an isoechoic to hyperechoic nodule with a nice halo, smooth margins, and peripheral vascularity. So isoechoic, nice halo, smooth borders, peripheral calcification, vascularity, excuse me. Similarly, what we call spongy lesions. These spongiform or spongy lesions, sometimes they can be difficult to distinguish from a solid lesion with multiple cysts, but oftentimes you'll see this characteristic sponge-like appearance, and these nodules tend to be this is a benign characteristic, and these nodules tend to be benign, especially when they're also characterized by peripheral vascularity. Now moving on to sonographically suspicious nodules. So these would be lesions that are hypoechoic, that have irregular margins, that have punctate microcalcifications, and intranodular flow. So first, I hope you can easily see a nodule with a lobulated, invasive-looking border. Similarly here, a nodule that appears to be invading into the surrounding tissue with a lobulated border. Taking that one step further, a nodule that's with a lobulated border, irregular border, that now also has these punctate calcifications. Same thing here, punctate calcifications, a nodule that's hypoechoic with irregular borders. Similarly, a hypoechoic, possibly cystic lesion with a component of solid tissue that's highly vascular, and a nodule that's characterized by significant intranodular vascular flow. So now, having said all that, 2/3 of benign nodules have at least one positive ultrasound predictor of those that we've discussed for thyroid cancer. And similarly, about 2/3 of papillary cancers have at least one non-suspicious ultrasound feature of those that I've mentioned. So the way that sums up is that while we wind up having a high specificity or a tolerable specificity for most of these findings that we discussed on ultrasound, the sensitivity winds up being quite low and not appropriate for a screening test, which is what we're trying to do here, is use the ultrasound as a screening test to screen thyroid nodules for benign versus malignant characteristics and take the next step. So, and of course, for a diagnostic test, as I mentioned, you need to have high sensitivity. And so that's why ultimately we still need to rely on FNA, which has a very high sensitivity and high specificity. And the way thyroid ultrasonography and the characteristics of these nodules, as I've mentioned, are currently used is to risk stratify nodules and make a decision on where they lie along this pathway and make a decision on the indication, weak versus strong, to proceed with an FNA biopsy. So purely cystic, spongiform, as I mentioned, mixed cystic versus solid, and then as you go higher, solid and hypoechoic, microcalcifications with irregular margins, and then, as Steph will talk about, the presence of lymph nodes, extracapsular invasion, and the one thing that's not on here is the vascular flow. And essentially this is how thyroid ultrasonography should be used by all of you in your clinics as an adjunct tool to help decide which nodules look more suspicious and are more likely to yield a positive result in a multinodular gland, and also which nodules that may even be smaller than a centimeter you may want to decide to biopsy in a particular patient, either because of the ultrasound findings, as we've discussed, that are suspicious, or a combination of their personal history, family history, radiation exposure, etc. So that's all I had for you this morning, and Steph will follow up with the advanced section. Thank you very much. Should we hold questions till later? Yeah. Okay.
So that was sort of the basics, what you look for a thyroid, what you look for in a nodule. And I'm just going to move on and talk a little bit about now, once we see a nodule, once we think it's suspicious, how to perform an FNA, talk a little bit also about the identification of abnormal lymph nodes in patients with thyroid cancer, and at the end just touch a little bit on other uses for ultrasound, specifically identifying parathyroid adenomas in patients with hyperparathyroidism using ultrasound. I see people fanning themselves. Is it really hot in here? In general, yes. Andrew, could you just go out and see if they had said it was hot, and I was so freezing when I started this that I was like, there's no way it's going to be too hot in here. But even I can feel that we'll try to put a little air on. Okay, so I've already gone through this. Okay, so I'm going to just start with a little bit on fine needle aspiration. So this is just the chart from the 2009 ATA guidelines on the management of thyroid nodules and thyroid cancer. So the key here is that when you're making a decision of which nodule to biopsy, it's not just you have a nodule, you're going to do a biopsy. There's things to think about. Just as Andrew pointed out, nodules that on ultrasound appear suspicious versus those nodules which, based on their sonographic appearance, really appear very much like a very typical benign nodule. So we use, in the guidelines, what they've put together is this chart which combines, 1, the sonographic features, 2, the size of the nodule, and then 3, issues of high-risk history. So things that are high-risk history are people who were exposed to radiation as a child, people with strong family histories of thyroid cancer. So people, when you have a patient who does have certain background risk factors, you may consider a biopsy of a nodule that might be smaller than someone who doesn't otherwise have those risk factors. So if we just look at this, you'll see high risk features as well as suspicious sonographic findings, microcalcifications, hypervascularity, even a teeny tiny nodule, 5 to 9 millimeters, you might want to consider doing a biopsy. I would not standardly do a biopsy on a small nodule like that, but really when it looks very suspicious or the patient has a really concerning history, it's certainly something to consider. And even if they have a high-risk history, without a lot of sonographic findings, you may want to consider a biopsy, but it's not that recommendation is actually an I, which means it's not necessarily recommended. It really needs to have sonographic features. If you find cervical lymph nodes, abnormal cervical lymph nodes, and I'm going to show you what that looks like. So if you do an ultrasound and you see a small nodule that may look a little bit suspicious, but it's fairly small, and you look at the side of the neck and you see an abnormal lymph node, you certainly should do a biopsy either of the lymph node or of the nodule. So identifying an abnormal lymph node is one of those higher risk factor things that would prompt the biopsy. But other than that, if you just have a nodule, you don't see any abnormal lymph nodes, you have no other history, if you have a nodule that does have microcalcifications, or it's a very solid hypoechoic nodule, that's something you would consider a biopsy as long as it was over 1 centimeter, not if it was smaller than that. As we move on, if it's solid and either iso or hyperechoic, little less suspicious, because as we said, the hypoechoic is the more suspicious finding. We would only do a biopsy of a solid iso or hyperechoic nodule. It would need to be a little bit bigger, now getting more towards 1.5 centimeters. And then if you have these mixed cystic and solid lesions, things like that, you're starting to say, again, larger nodules, greater than 1.5 to 2 centimeters. And if it looks predominantly cystic or that spongiform appearance, you would only biopsy those nodules if they were very large, greater than 2 centimeters. So we just are trying to make this decision for biopsy, kind of combining everything that we know, history, size, ultrasound features, to try to have a more a practical and thoughtful approach to biopsy. If something is a purely cystic lesion, no solid component at all, FNA is not recommended for pure cysts within the thyroid. So every nodule that you have in your thyroid does not need to be biopsied with ultrasound guidance. We generally do most of our biopsies today with ultrasound guidance, but it's not an absolute thing that has to be done. There is still a role for biopsies with palpation. But there are certain nodules which absolutely should never be biopsied by palpation, because you have a higher chance of not getting a good result or a false result. So if the nodule is very difficult to palpate, it's really hard to biopsy it by palpation, obviously. So things that are very posterior and things like that, nodules that are seen on ultrasound and not clearly palpable, would really require ultrasound for that biopsy. Nodules that are predominantly cystic but may have some solid component, you really need the ultrasound to guide you in doing a biopsy. If you just stick the needle in by palpation, you're more likely to just be in the fluid component and not necessarily going to be in the solid component. If you have a nodule that was biopsied in the past by palpation and it was non-diagnostic, generally we do recommend a repeat biopsy be done with ultrasound guidance. And lastly, if you have a nodule that was biopsied previously and was benign, but as you followed it with ultrasound, it's growing, it raises this question that maybe that initial biopsy wasn't accurate, and the repeat biopsy should be done with ultrasound guidance so that you have more accuracy and know that the needle was truly in the nodule. And these are just some examples of nodules that would really be more difficult to biopsy with palpation. This is a posterior nodule. You can see it does raise the upper border of the thyroid, and you likely would palpate that there was an abnormality on this right side of the thyroid. But the nodule itself is actually quite posterior. And if you just biopsy by palpation, generally you're biopsying more superficially with that technique. And your likely is that your needle is going to be in that superficial normal tissue and not make it all the way down to the nodule. And so by knowing where that nodule is on ultrasound gives you a better sense that this is a nodule that would be better biopsied with ultrasound guidance. Here the second nodule is again a posterior nodule with more irregular borders. Again, very different. This one's not even palpable, so certainly not one that could be biopsied without ultrasound guidance. And here's an example of one of those nodules that's predominantly cystic, but there is some solid component in two different areas. When you put on the Doppler, you can see that it's this area over here that's truly vascular, and that would be the area that really needed to be targeted during a biopsy. And again, you'd need the ultrasound to really target that area and know that your needle was there and not, even though this nodule very well may be a palpable nodule. And this is just some data to say why we do this. And basically, in these two studies that are now relatively old, they looked at the false negative rate when that biopsies were done by palpation. It's quite low, somewhere between 0.5 and 2.3%. So it's low, but it's not zero. And when they then used ultrasound guidance, you can see that the false negative rate does drop significantly. And really what they found is that the reason for these false negative results were really due to sampling error. It was times when they were biopsying cystic lesions and not in the solid component, or times when the actual nodule itself wasn't biopsied because of its location. So when we do a biopsy with ultrasound, there's really two ways to do it. You can do it all by yourself. You hold the ultrasound probe in one hand, you hold the needle in the other hand, and do the biopsy on your own. The other option is approach using two people, where one person actually holds the probe in place and one person does the biopsy and has the needle. It can help, especially as you're learning, to have the two-person approach, because getting the coordination of holding both the probe and the needle can be quite difficult. So when you do a biopsy, you don't need any special tools. You don't need echogenic needles or anything like that. A 1.5-inch needle, gauge between 23 and 27 gauge, is perfectly fine, and that's all you need. You can attach that needle to a normal 10 cc Loralox syringe. You can also, some people biopsy with just the needle alone, not attached to anything. I generally use a syringe because it gives you something to hold on to. We generally will break the seal, put a little bit of air into the syringe, and then in general, depending on your technique, you need to use a cover of the probe and sterile gel if your needle is going to be really close to the probe. If you're able to do the biopsy such that your needle's a little bit further from the probe and not going to come in contact with the gel, it's not necessary. So it really depends on what you're doing. The issue is if you go through gel with your needle as you're doing the biopsy, that gel is going to hamper the sample and make it very difficult for the cytologist to interpret it. The gel messes up the cells. You just need to clean the skin with some alcohol. You don't need to use a lot of betadine or anything like that. A little alcohol is perfectly fine. And you don't need any special guides. A freehand technique is just fine. You can just move the needle up and down within the nodule and then prep the sample, which Dr. Massol will go over. So these are just the two most common techniques that are used for ultrasound-guided biopsy using a linear ultrasound probe. So here the probe is on the patient's neck. This is called the parallel technique, when the needle goes in just parallel to the plane of the probe. The perpendicular technique, here's your linear probe. Your needle's going to go in right at the middle, just perpendicular to the probe. And when you do these different techniques, you're going to see different things. So here again, the linear probe, here's your nodule. You bring your needle in just on the side of the probe, parallel to the sound waves going down, and you're going to then see the needle in the nodule. With that perpendicular technique, the probe's here, here's your nodule. Your needle's coming in right in the middle of the probe. All you're going to see in the nodule is a bright dot. Here's a bright dot. It takes a little bit of practice to get a sense of whether that bright dot is the tip of the needle or the middle of the needle, and that can be a little bit hard. It's a little bit easier, though, to get into the nodule with the perpendicular technique. And hopefully we'll have time in the practicum for you guys to try these different techniques, like I said, with the turkey breasts. So typically, most commonly, these biopsies are done with a linear probe like this. The probe's there right over the nodule. The needle comes in right next to the probe. There are also curvilinear probes which can be used for a biopsy. And with a curvilinear probe, your probe actually comes to the side of the nodule. Your needle comes in straight up and down. You're a little further from the probe, and you have a little bit of a wider plane, so it's a little easier to keep your needle in your plane throughout the process. So here's an example of an FNA with a curvilinear probe. You can see the nodule here. The probe is on the side of the nodule, and then you can see the needle within the probe throughout. But it does rotate. There's a little bit of a rotate. So even though your needle's coming in right from the skin, on your screen it comes in from the side of the screen, and it takes a little bit getting used to. So that's just a bit about biopsy, which nodules to biopsy and how to do it. I'm going to move on and just talk a little bit about the evaluation of lymph nodes. And the reason that we think so much about lymph nodes in patients with thyroid cancer is that about 42% of patients with thyroid cancer present with lymph node metastasis at the time of diagnosis. So it's really something that's not uncommon. At the time of diagnosis, 21% of these lymph nodes are macroscopic, meaning larger than a centimeter. And if you look at a large database, SEER database, about 22% of patients with papillary thyroid cancer will have lymph node metastasis at the time of diagnosis. This is probably a little bit of a more accurate number. That 40% is an older study and maybe not quite as accurate. But based on this finding, these are just what the guidelines have been put out as our recommendation. And the key here is that a preoperative neck ultrasound, when you have a patient who has thyroid cancer, had a biopsy, has thyroid cancer, is going to go to surgery, you really want to make sure you go back and do an ultrasound, look at the other lobe of the thyroid, look at all of the lymph nodes, and evaluate them before surgery, because lymph node metastases are not uncommon. If you see them prior to surgery, it really can help guide the surgeon and make sure the most complete surgery has been done, including a lymph node dissection. So on ultrasound, when we look at lymph nodes, a normal lymph node is going to be oval in shape. It's going to have a bright echogenic hilus, which is this little fatty tissue right in the middle of the lymph node that's going to look bright on the ultrasound. And the vascularity in the lymph node is going to be right within that fatty hilus. So here's an example of a normal lymph node. You can see it's oval. You can see this bright stripe right in the middle, which is that fatty hilus. And here's another example. The vascularity is not great, but you can see this lymph node here, that white stripe, and there is just a little bit of vascularity right within that hilar region and not anywhere else. Oh, this didn't come out very well, but this is just an example. The way the lymph nodes in the neck are broken down is into compartments. And so level 6, which is here, is the central compartment. Those are the lymph nodes right behind the thyroid gland in the middle part of the neck. And as we move into the lateral neck, we have levels 2, 3, and 4 in the side of the neck, and then posterior to the sternocleidomastoid, level 5 back there. And so these are the areas where you can get lymph node metastasis from thyroid cancer and the areas that are generally evaluated. The submandibular lymph nodes at level 1, very uncommon site for thyroid cancer to spread to that area. So now what do we look for when a lymph node is abnormal? Instead of that oval oblong shape, the lymph node becomes much rounder. In addition, the echogenicity, a normal lymph node is generally hypoechoic, whereas a lymph node specifically with papillary thyroid cancer, which is the type of cancer which most commonly spreads to lymph nodes, that lymph node will more likely be more hyperechoic or a little bit brighter. The hilus disappears, so there's an absence of that hilus. You lose that bright stripe. You can see cystic change within the lymph nodes, calcifications, and generally an increased vascularity, particularly in the periphery, and as well can be in the central area, as opposed to that little spot of vascularity right in that central hilum that we've lost. So here's an example. This is first just an abnormal nodule with irregular borders, microcalcifications, and then as we look in the lateral neck, this is an abnormal lymph node. You can see that this lymph node is round. It's round. It is somewhat hyperechoic, or more about the same as the strap muscles, and you've lost that fatty hilus. Here's another example, again, an abnormal nodule with microcalcifications, infiltrative borders, and as you look more carefully, you can see this abnormal lymph node here. It's very round. It lacks your fatty hilus. It does contain some pinpoint microcalcifications, and when we look at the vascular pattern on this lymph node, it has a peripheral vascular pattern. This is a very suspicious appearing lymph node and would warrant evaluation. And so from there, just again, if we look at what the guidelines recommend, they say that if you see an abnormal lymph node and diagnosing that would change your management. It is something that should be biopsied. You can send it for cytology. You can also wash out the fluid that you do when you biopsy a lymph node. You can wash it out and send it for thyroglobulin. Sometimes when you have a small lymph node, you may not be able to get tissue for cytology, but if you wash it out with a little saline and send it to the lab for thyroglobulin, you may see elevated thyroglobulin levels despite the fact that the cytology does not show a lot of cells. And that can be done even in a patient who has positive thyroglobulin antibodies. You can still measure the thyroglobulin in a lymph node washout. And just to conclude then, I'm just going to touch briefly on the idea of using ultrasound not just for the thyroid nodules and lymph nodes, but also when you have patients with hyperparathyroidism. So this is just a summary of the consensus guidelines that there have been now 3 NIH consensus conferences on recommendations for surgery in patients with primary hyperparathyroidism. So primary hyperparathyroidism is a really common disorder. You will see it all the time if you haven't already. The question is, who needs surgery for this? Most people are completely asymptomatic and really don't have a lot of problems related to the hyperparathyroidism. So we're looking for reasons to do surgery. And in general, the current recommendations are very high serum calciums, 1 above the upper limits of normal, reduced creatinine clearance, osteoporosis, and a young age. Any of those factors in the setting of clear hyperparathyroidism is a reason to consider surgery. It used to be that they also thought very high urine calcium was an indication for surgery, and that's actually been eliminated from the recommendations. And the idea is, though, if you have someone who meets these criteria, you're going to recommend parathyroid surgery. One of the keys, as these guidelines point out, is that, or this conference points out, is really you want an experienced surgeon. Parathyroid surgery is really best in the hands of someone who does it a lot. And the idea nowadays is that people really want to move towards the minimally invasive parathyroid surgery. Instead of the traditional surgery where you would explore all 4 glands, identify the abnormal gland, and remove that gland, this approach, you just go into one side of the neck and you remove the abnormal gland, monitor the parathyroid hormone level intraoperatively to confirm that you've removed all of the abnormal gland. And the nice thing about this surgery is that it's a shorter surgery, the incision is smaller, and there are fewer complications, most specifically postoperative hypocalcemia. With that traditional surgery, when you had to explore all 4 glands, it was quite common to at least have transient hypocalcemia after the surgery. If you only go in on one side, much less likely. The issue with this surgery is that you have to identify the abnormal gland preoperatively. And the other issue is that there are cases where patients have double adenomas, and that can be missed when you use this minimally invasive approach. And so the idea of utilizing ultrasound is a way to help the surgeon guide them and identify the abnormal parathyroid gland. In general, you can look for normal parathyroid glands when you do your ultrasound, but you're probably not going to find them. They're very small, very difficult to see a normal gland. But when someone does have an abnormal parathyroid gland, it becomes more clear. So here, just posterior to the posterior aspect of the thyroid and transverse view is this hypoechoic, very smooth oval lesion, very classic appearance of a parathyroid adenoma. And here's that same lesion on the sagittal or longitudinal view, and you can see hypoechoic, very smooth, regular borders. And the key with identifying parathyroid adenomas is really pattern recognition. They're looking at the appearance, that hypoechoic oval lesion, looking at the location. On that transverse view, you're going to see the parathyroid just posterior to the thyroid gland itself. And here's an ultrasound showing that same thing, that lesion there. And on the longitudinal view, you can get even more information regarding whether this is a superior or an inferior parathyroid gland. Very difficult to determine that on the transverse view. But on the sagittal view, the inferior parathyroids will be just below the inferior margin of the thyroid gland, where the superior parathyroids will be in the midline of the thyroid gland on longitudinal view. And here again, as a real ultrasound, you can see this oval hypoechoic lesion, inferior pole of the thyroid, superior pole of the thyroid. This is right at that midpoint, so most consistent with a superior parathyroid adenoma. And on the other hand, here's our inferior pole, superior pole over here. This lesion really more off the edge of that inferior pole, more likely to be an inferior parathyroid adenoma. And there's also a very classic vascular pattern for these parathyroid adenomas. It's called a polar vascularity, more of a feeding vessel. So you'll see one vessel coming into the lesion there, as opposed to that hilar vascularity of a lymph node where it was right in the center. And here's another example of a feeding vessel coming into or polar vascularity within that parathyroid lesion. So just to summarize, the keys when you're looking for parathyroid adenomas, the appearance, oval, homogeneous, hypoechoic, the classic location, and the polar vascularity. And then just experience by just doing this and looking and trying to see them in the patients that you do see with hyperparathyroidism, you'll start to recognize what they look like. So with that, I know it was a lot of information in a short time, but we wanted to just kind of expose you to all of these different aspects of ultrasound. And I'm going to step aside and I'm going to invite up Dr. Massol, who is a cytopathologist, and she's going to come and talk a little bit about cytopathology from fine needle aspiration. And when we go over to the practicum, she's going to have a station where you're going to have a chance to prepare slides using liver, look at them under the microscope, and help you to learn about adequacy.
So you guys have now gone over which nodules you're going to biopsy. You've gone over what all the features are. You know how to do the FNA. Now the question is, you've done the FNA. What do you do with the sample? And how do you know what you got, right? So with that, we're going to look at just a few of those kinds of things. So to do this, you're going to see everything when we go next door, but you have to have your glass slides. And remember, these glass slides are going to get dipped in alcohol for staining purposes. So anything that's a marker or a pen is going to wash off when you label it. So label your slides with pencil, okay? You're going to look at, we'll talk about doing pap-fixed slides, which are the alcohol-fixed ones, and we're going to talk about doing air-dried slides, which are the ones that are done with the diff quick or the rapid stain. That's the stain that we're actually going to practice next door, because the diff quick only takes about 1.5 minutes to do. Your pap stain, while there are ultra-fast pap stains out there, most places do not use them. So that stain takes about a good 1.5 hours, so it's not something that you'll typically participate in. Most places will use some sort of a rinse. Right now, many of them are alcohol or formalin-based. Many places are switching over to more of a molecular-friendly fluid for your rinse, so that as we progress through this era or dilemma of molecular, we can decide which nodules we want to reflex or send testing off for. And then your requisition form. We're trying to train cytopathologists with the same lingo that you're learning and using for ultrasound, okay? So the more information you can give them that the nodule is hypoechoic or hypervascular or circumscribed or irregular margins, the more specifically they can help you with what your diagnosis is, okay? In the new Bethesda terminology, there is the option that your cytopathologist can tell you if you give them all cis fluid, instead of calling it unsatisfactory, they can tell you that it's consistent with a cis, but you have to give them that history, that by ultrasound it's consistent with that, or you're not going to get that. You're going to get unsatisfactory, because they cannot tell you that without knowing that's what you are already thinking, so that the two go together, okay? So the requisition form is actually very important. All right, so this may be what your setup would look like. In my clinic, this is how things look, and I have a container off to the side here, which is for my air-dried slides that I stain while I'm in clinic. The green top tube then has alcohol in it, and that's what I put the slides in immediately for the pap stain. This is going to be an alcohol. You're going to see these stains next door. This is going to be fast orange or orange G, and this is going to be hematoxylin. Some sort of a tube for a rinse, and then my slides that I label with the patient's name. All right, so there's lots of different ways that you can prepare the sample once it comes out of the patient. The gold standard is to make smears, all right? And smears can be exactly that. They can be where you take the sample and you smear it out. The gold standard truly means glass slides that you make at the time that you're doing the procedure. We're going to show you another real quick method right across the hall, and I'll go through it briefly here. It's called a book method or a pop-apart method. So when you're over there, we can practice making slides if you haven't done that with smear methods, or this pop-apart method. Cytospins are what we make from that rinse media. Typically, they're just a cytocentrifuge concentrated sample, and it gets a pap stain on it. And then a cell block. And cell blocks are very rarely used for thyroid FNA. If you tell us they have a history of malignancy and you're worried about metastatic disease or something like that, we may want to do a cell block looking so that we can stain it for other things. It takes a little bit larger sample to make a cell block from. We can actually do cytocentrifuged or cytospin samples and do immunohistochemistry off those, which requires not as much cellularity. So don't think that even if you don't get a lot of cells that you can't get stains. You can still ask. All right, the way the slides can be done that we're going to talk about is air-dried slides. That's your first type. And alcohol-fixed slides. That's your second type. The air-dried slides are the ones you're going to use today, and those are the ones that go through the diff-quick or rapid staining. Okay, it's a modified Wright-Giemsa Romanowski type stain like you would use for peripheral blood smears, and that's what we'll stain things with today. If you have looked at reports that come back and say air drying artifact or something like that on the report, that's the ones that go this second one, the alcohol fixed slides. If they don't get into the alcohol immediately, the edges of the smears start to air dry, and that's when you're getting the comment of air dry artifact. The first kind that we stain in clinic and do the difficult kind, those you want air dried. You're never going to get a comment like that. That's the whole purpose of those. So these air dried ones allow us to look at things immediately because we can use the stain in clinic. It does change the cells a little bit in that they look a little bit bigger. So if you're used to looking at them in a pap stain with your pathologist, don't be surprised when the cells look slightly larger on the diff-quick. The alcohol-fixed slides, though, provide the opportunity to do the Papa Nicolau stain, and those are much better for nuclear detail. We're going to go over that in just a second. So the diff-quick stain, while we can use it in clinic, the other benefit of it is that it lets us see and appreciate colloid a whole lot better than a pap stain does. So in thyroid FNA, the really good thing about the diff-quick is that it allows you to look at something rapidly, it allows you to look at something while the patient's there with you and you can determine adequacy, and it gives you a better appreciation of colloid. The pap stain, on the other hand, you need to put into the alcohol right away. It's something that's going to come out either later that day or the next day. And the thing that we really like about it is that all those grooves and inclusions that you hear us talk about for papillary thyroid cancer, that's where we can see them the best. So pap stains really help us confirm those great nuclear details that we all look forward to seeing for papillary thyroid cancers. Now, hematoxylin and eosin, or the H&E, is the classic surgical pathology stain. So when the thyroid comes out and we cut it up and we do sections with it, you get an H&E slide. If you do a cell block, you'll also get H&E slides. Okay, so that's when that stain's used. It's not a regular cytologic stain at all. This may be what your setup would look like. Your first container there is clear, and that's the alcohol. That's what you're going to fix the slide in once it's dry. The second container, depending on the brand you buy, is either called Orange G or Fast Orange. And then the last container on the end is really a dark blue or dark purple, and that's your hematoxylin. All right, so I'm going to run through just briefly how to do this other methodology, which is called the book or the pop-apart method. And to do that, when you do your FNA, you take your sample and you put a small drop into the middle of the slide now instead of closer to the end where you would normally put it to do classic smears. You're going to take the slides and you put them like a sandwich on top of each other, okay? Once those two slides are on top of each other, you're going to let that sample, just by capillary action, spread out as far as it'll spread, just to make it as thin as possible. And you can sort of see the outline of the sample here. Now it's spread all the way, kind of like this. So now it's spread as far as it's going to spread, and it's called the book method because you can either open it just like this or you can just pop them open, so it gets the name pop-apart or book method. And it gives you two slides now that are mirror images from that same FNA. So one can go immediately in alcohol for your pap stain, and one can be air dried, and you stain while you're there with the patient. You can determine adequacy from it. The pathologist will look at that one as well, look at those cells. They'll be able to see colloid. They'll be able to say, if there's something funny on this diff quick, they can go to the pap stain and confirm it on the pap stain and see all the lovely nuclear detail. So it's a very nice sample for us. When we do diff quick staining, you want to make sure that the slide is entirely dry, okay? So when you're over there, I'm going to show you a couple of them. When you put the sample on the slide, it looks like wet paint, okay? It's real shiny. Once the sample's dry, it has that dull, flat paint kind of look to it. It's no longer shiny at all. Once it's dry, you're going to stick it into the 95% alcohol for approximately 30 dips or 30 seconds. You're going to transfer it to the orange container for about 30 dips or 30 seconds, and then into the blue container for about the same. The last container you're going to see on the table is just going to be water. That only takes 4 or 5 dips just to rinse off the extra stain. You will have taken that glass slide and put your initial on the front of it. Make sure that initial is facing you. Pick up a piece of gauze and wipe off the extra water off the back, otherwise it sticks to the microscope. Now I'm going to tell you this one more time. Make sure your initial is facing you and you wipe the back off, because someone's going to wipe their sample off the slide, okay? It happens all the time. Trust me. All right. The whole reason for doing this is so that we can look for adequacy while the patient's there. You've done the F&A, you know what you want to biopsy, you've gotten a sample out. Now really you want to find out, do you have enough cellularity that you're actually done, or do you need to stick the patient again? So the diff quick allows you to see cellularity. It lets you look at different cell types. It lets you look at colloid. You can see architectural fragments. So it provides a lot of opportunity and a lot of information. The next problem, though, is what's the definition of adequacy? There's been several definitions of adequacy over the last several years that have been floating around out there. And I just want to give you a little of the history behind it to how we got to where we are today. So it started out saying, okay, well, maybe 5 or 6 groups of cells was enough. If they have 10 to 15 cells in them, okay, then we have enough cells there. Then we got to, well, we really need more than 8 cell groups, and it should have at least 10 cells in these clusters. And then our governing body, which is the Papa-Nicolau Society, came up with sort of trying to summarize the different definitions out there. And this first definition is actually the one that I used, which is the 6 to 8 groups of well-preserved follicular cells with 10 or more cells per group. So that's what we're going to discuss next door. There is an additional published definition out there, which is the 6 groups of follicular cells. But now it needs to be on at least 2 slides from separate passes. So at this point, I think we need to diverge just a minute and say that adequacy really is somewhere around, if you take all of these different numbers, say 100 cells, right? You can typically get that in a pass, maybe 2 passes. And if you have a small nodule, that may be enough to sample the nodule, right? Because you've put the needle in different places. If you have a 5-centimeter nodule and you've only sampled this part and this part, you may not feel that you've adequately sampled the nodule. So adequacy really depends on, have you adequately sampled the nodule, in which case you should target those areas that they just discussed with you and go, find those suspicious areas within the nodule so that you can feel comfortable with sampling the nodule, and then your adequacy that you get is really representative of your most suspicious features within that nodule. So what do we look for? You're going to look at some of this across the hall. Follicular cells typically have nice round nuclei. In benign nodules, they really don't overlap a whole lot. The cytoplasm is nice and thin and lacy, and they're very respectful of each other. This cluster, on the other hand, they overlap, they're elongated, they're not round anymore. This was a follicular variant of papillary. So the thing that we're looking at this is clusters. See how the cells all stick together? Because in a minute we're going to discuss the things that don't stick together that you see on the slides. So the important part about adequacy is finding clusters of cells, because remember, follicular cells and Hürthle cells are what make up the malignancies, right? So when we have other cells in there, if you have Hashimoto's thyroiditis, you can have macrophages, you can have lymphocytes, but those don't make up the malignant parts of the lesion, right? So you don't use those when you count cellularity. So the only cells that count are clusters of cells that are follicular or Hürthle in nature. So here's another example of what follicular cells can look like. I'm sure you've heard of the microfollicular patterns that can be seen. So here's a nice microfollicle in the center with some inspissated colloid. And this is Hürthle cells. So Hürthle cells are much larger cells, have much more abundant cytoplasm. Instead of the nucleus being in the center of the cytoplasm, now you see the nucleus sort of sits off to the side. Here you can see the nucleus, while it's round, sits over to one side. The cytoplasm occupies the other side of the space. And the cytoplasm is a little bit more granular, which we'll look at here. So here we can see again the nice round nucleus. We can see the abundant cytoplasm. And we can also tell that there's little specks in the cytoplasm. So this is a cluster of Hürthle cells. Now, we always like to see colloid because that makes us feel better too, that we're not discussing follicular lesions. So colloid can look in many different ways. See the little folded areas within. This is called a pattern of draped silk colloid. So if you're familiar with fabric and you take and drop it on the floor, it gets all ripply. This is called the draped silk pattern. If you look at this cluster over here, this has got some thinner colloid in the back, and this is called fluffy colloid. So we like to give it lots of names. Now, the cells that will confuse you for those Hürthle cells are these macrophages. But what did I tell you? These are going to have round nuclei. They're going to have speckly things in the cytoplasm. But there's typically a lot more cytoplasm. The speckly things are many different sizes. There'll be big speckles, little speckles. There'll be clearer vacuoles. And they're not going to be tightly stuck together. They're going to be single cells here and there, or a couple clustered like this, but they're not going to make big clusters of cells. So if you stick to looking for the purple clusters, you'll stick to looking at the epithelial components. Now, there used to be some discussion, unfortunately most of you haven't had to deal with this, of having a CLIA license to do adequacy in your office. As of January 1st this past year, CMS took that away. You do not have to have a CLIA license to perform this in your office anymore. And there have been some updates in coding. When you do your initial biopsy adequacy determination, you use the code 88172. And then for each additional pass that you do to determine adequacy, you use the 88177. Now, when you dictate, just like you do for your ultrasound, what you saw, the size of the nodule, calcifications, hypoechoic, vascular, all that, it's just as important when you dictate your note for your procedure that you say on pass 1, there are scant follicular cells and macrophages and colloid. Pass 2 had lymphocytes only. Pass 3 had adequate cellularity for Hürthle cells. So you have to document what you saw in each of the passes to give justification for why you did each sequential pass, okay? So as you get into this and you start to do more and more looking at slides and staining and things like that, just remember that just like you do for your ultrasounds and your procedure notes currently, you have to have justification for why you do each additional pass if you want to get paid for them. That's all I have from this, and we can go through any more of this when we get across the hall. Are we doing questions now or over there? Okay.